Just to remind everybody before I go into my welcoming remarks, this is the first meeting that will be recorded, so you'll be able to see yourselves on YouTube after the meeting. That also means if you want posterity to hear what you've got to say, you need to remember to switch your mic on, please. I'm just going to ask Gillian to reassure everybody about how the material recorded today will be treated.
Thank you, Chair. In line with what our common practice in the Council, the meeting will be recorded and then our colleagues will do the technical things that they have to do with the video, which I believe is rendering and editing and all these things. And then it will be uploaded to YouTube once that is all complete. So it doesn't always happen, it's not necessarily going to be immediately after we finish the meeting today. Our council meeting on Wednesday didn't finish till just after 6:30, and I think it's just going live on YouTube this morning because there was a lot of work to be done to it. So hopefully, if it's not by close of play today, it will be early on Monday that the video will go up, and it will be retained on YouTube for 12 months.
And archived?
Archived thereafter, yeah. Yeah.
Okay. Does anybody have any questions on that? Okay, good. Well, this is my first meeting as chair, so welcome everybody. We have a number of changes of our membership. Firstly, in terms of people for whom this is the last meeting, I'd like to thank Helen McKinnon for her contribution not just to the IJB but to the Pathfinder Board. Helen's fulfilled an absolutely critical role. We have benefited enormously from her judgment and advice, and I know she's working hard on succession, so we'll have somebody, I'm sure, equally capable sitting in her chair at the next meeting. Thank you, Helen. Chris, I'd also like to say this is your last meeting, and I'd like to thank you for all the hard work you've done in your time on the board, and particularly in terms of getting the Audit and Performance Committee up and running. You've also worked tirelessly behind the scenes in ways that most members may not be fully aware of, so thank you very much for your contribution. And I know although this is your last meeting, you are going to continue to contribute beyond this meeting until you formally step down with the next Audit and Performance Committee, so thank you very much for that. And this is both hello and goodbye, as I understand it, which has got to be a record that will never be beaten in terms of membership of the IGB, so welcome to your first and last meeting. And I look forward to a full contribution in the one opportunity that you have, so thank you. Okay, well, we'll look forward to that. And lastly, this is Lorna's first meeting, I believe, from NHS Tayside, so Lorna, welcome. And we look forward to working with you over the coming months and years. Since we've last met, I wanted to highlight a couple of things. The voting members have been out to meet with the Governor of Perth Prison and have also had a tour around Perth Prison to see the facilities that we have there. And I know Perth Prison has had a rather more formal inspection subsequently, and we're no doubt getting feedback on that in due course. We also last week had an induction day for new members. We're clearly going to have to be running induction days fairly frequently during the course of this year, given the rotating membership we have. I attended that, so for me it was a re-induction, and I found it extremely useful as a refresher, and would encourage other people who, if they think they're getting a little shaky on what we're doing, might find it useful as well. It reminded me of a couple of things that I just wanted to highlight to the committee, to the board. Firstly, just to remember that when we're here, we are members of the IJB, and while in our other lives we all wear many hats, the hat we're wearing today is the IJB, and that should be the only focus that you have in terms of your thinking and decision making. Secondly, we're an integrated board. We have partner organizations. The aim here is to reach consensual decision making, and that really is very much implicit in the legislation that we seek to be very consensual. That doesn't mean we don't exercise due scrutiny and challenge, but the tone of the way we do things is to be consensual. And that was a very useful reminder for me from the induction session. I'm going to close my remarks here and just go to Scott or Julian for apologies.
Thank you, Chair. We have apologies today from Dr. Robert Peat, from Dr. Daniel Carey, Dr. Alistair Noble, from Linda Lenny, but we have Sandra Auld substituting. Apologies from Bernie Campbell, and we have Maureen Summers substituting. And also apologies from Diane Fraser, Evelyn Devine, and Kerry Wilson, unless there's any others.
Okay, can I move to declarations of interest? Are there any declarations of interest with regard to this meeting? I'll take that as a no, thank you. If we could move on to the minutes of the last meeting, and I would just stress here that we're here simply to confirm whether or not this is an accurate record of what took place at that meeting. We're not here to obviously re-enter into any of the discussions that occurred at that meeting. So if I can go through page by page, if people wish to comment, then please chip in. So page 1, page 2, page 3, page 4, page 5, page 6. Okay, could I have a proposer and seconder for the minute, please?
I'll propose the minutes, Chair.
Thank you. Second? Jane, thank you. Okay. Action point update.
So thank you, Chair. I'd like to just bring your attention to item 29, and this is the item on the Joint Workforce Organisational Development Strategy and Workforce Plan. So you'll see from our history that there have been a number of delays in this process, and this is largely because the workforce landscape is changing and that we're in receipt of emerging guidance from Scottish Government about a number of key strategies. So one has been the general practice, the primary care services contract that is under discussion later in the agenda today. Under the new arrangements for general practice, you will see that there's commitment to a whole new raft of workforce to support the primary care team. And the second piece that I'd like to draw your attention to is the Commitment 15 under the mental health strategy, which is a commitment across Scotland to bring something like 800 additional workers in to support mental health and well-being in 4 settings. First of all, in the general practice. Secondly, in accident and emergency. Thirdly, in and around police stations. And finally, in the prison system. So the reason why we do not have a settled state with the workforce plan is that the landscape is constantly shifting. And we are working in real time now to determine our offer for, or our proposals for the additional 800 commitment under Commitment 15 of the mental health strategy. And we will be hearing later in the agenda today about the changes that are happening for primary care, so I'll not go into detail on that one. Happy to respond to any questions about that. Okay. And most of the other actions, I think, are referred to the agenda this time, so I don't think we need to go through any of them in detail unless any people, any of the members of the board have any questions. Maureen.
Sorry, in the last meeting, which I didn't attend, but there was at some stage that you promised to bring a transport update for the mental health
Right.
transformation, and I don't actually see that in the papers here. So,
thank you, Maureen. The issues about transport are being discussed as we speak. So when I was with the executive team of the council last week, we were in discussion about this, and Barbara Renton, who's the executive director of the Environment Service, is working with us to make sure that the transport arrangements, not just for the mental health system, but also for other parts of the public sector which are likely to change, are connected with our work. However, this is not a completed work, and we know that it will need to be addressed prior to any moves that happen for people under the approval that was granted on the 26th of January for the changes in the mental health system.
Yeah, because the concern is too that the transformation is likely to be accelerated because of work challenges. So I would really like, an update as soon as possible.
Maureen, I'd be very happy for that to happen. And yes, you're right. We are trying to accelerate the process, and that's for reasons of making sure that the service can continue safely and effectively. However, we do recognise, as we promised at the start, that this is a fundamental factor that needs to be addressed before we can make any of the moves. Thank you.
Okay, thank you, Rob. Under matters arising, I just wanted to brief the board on our responses to the letter from the council that was a notice of disapproval with regard to Beechgrove. I received a letter from Councillor Lyle to which I responded. I also had discussions about Councillor Lyle's letter with the Chairman and Chief Executive of NH Tayside. Their response was to commit to having a meeting with all council leaders, chief officers across Tayside in one room so that we could share a common vision. That meeting hasn't yet been organised, but I believe is on the agenda. I met with Councillor Lyle earlier this week to discuss our exchange of letters. I think we are both in agreement that as much as anything, we need to get better at communicating between the two bodies. On that basis, we have agreed to start in September monthly meetings between Councillor Lyle and myself and the Chief Officer with an open agenda to discuss any issues we feel are relevant to making sure there is good communication and good cooperation between the two bodies. And it's certainly my intention that we don't provoke a letter like that again and that we're working as closely together as possible for the benefit of the people of Perth and Kinross. Does anybody have any comment or questions on that?
Thank you, Chair. Yes, I'd just like to thank yourself and the Leader of the Council for taking the bull by the horns and getting together to talk about it, and I'm encouraged to learn that there are going to be regular meetings to ensure that there isn't a recurrence. Thank you.
Thank you, Eric. That was the only issue I had under matters arising. Does anybody else have anything?
Just one point on the minutes, and it was passed before I realised, but I was asked to note that the lack of service user and carer representatives' questions and responses being recorded in the minutes, and we'd like to see a bit more of that in the future.
Thank you, Maureen. We have discussed it at the Audit and Performance Committee's last meeting that internal audit highlighted our minutes was somewhat skeletal. So we will be working to improve the quality of minutes, and we would appreciate you keeping an eye on that on our behalf so they reflect what they should. Obviously, with meetings being recorded, people will have an opportunity to see everything they wish to see. But it is our intention to make sure that the quality of the minutes improves through time. I think it's IJB membership update.
Thank you, Chair. As you have already alluded to yourself in your welcoming remarks, there are a number of changes to membership in the board. Councillor Ahern will be leaving the board, as will Councillor Jarvis after her short tenure of office, and being replaced with Councillor Purvis and Councillor McDade, who will be returning to the board. And as the Chair also mentioned, Helen, this is Helen's last meeting. Helen is moving on to pastures new, but I know that she's already working with Rob and her colleagues in PCAFs to look for a successor. We have Lorna joining the board this morning. We will have an additional NHS member, Professor Nick Beach, who will be joining the board, but that needs to be confirmed by NHS board next week. So whilst he's been nominated, that needs to be formally approved before he can attend a meeting of the board. I think that's all the changes that we know of just now, other than those that are in the paper. I think the points that we would want to particularly pick up are with regard to the Audit and Performance Committee and for the need for the board to agree to nominees from the NHS membership to the Audit and Performance Committee, and also for the board to agree a chair of the Audit and Performance Committee once Councillor Ahern's tenure of office finishes on the 21st of July. The rules are such that someone who is leaving the board has a month from the date of that decision. So I would ask the board to consider the nominations from the NHS side to the Audit and Performance Committee, and also consider the appointment of a chair to the Audit and Performance Committee. And I realise, and it's my apologies, that Councillor Colin Stewart is here in the first meeting as the Vice Chair of the board. My apologies for not having mentioned that.
Sorry, Stephen.
Yes.
Sorry, Chair. Can I just add, to that, we'll actually, the employee director who sits on the board here as a non-exec through NHS Tayside, that's a vacant post, and the election takes place on the 4th of July, so there will be a nomination, and that will be an additional person to replace Judith Golden in her capacity on the IJB. Is my understanding?
No, sorry, Chair, there are 4 places on this board for NHS voting members, and my understanding is that we have Stephen, we have Dr. Pete, who's unable to be with us today, we have Lorna Burr-Stewart, who's joined us, and the recommendation is that the 4th voting member from NHS board will be Professor Nick Beach. My understanding is that is the position of NHS Tayside, and obviously I can't comment further than that.
Okay, I'm happy to take that back and come back through Rob. Okay, thanks, Chair.
Yes, Chris.
Yeah, just to note that you'll need a replacement for me on the audit and performance. That wasn't mentioned.
No, it was, and we are aware of it, Chris. And I sent a late email to somebody last night asking if they would be willing to do it. Right now, there is only one person who could do it, I think. So yeah, we're working on it. I think the employee director, as and when they're appointed, can obviously attend any IJB meeting they wish. So there will still be the appropriate representation in some sense.
Okay, thanks for that, Steve.
So I'm looking for 2 names.
For what?
For the Audit and Performance Committee.
I can't give them to you because I don't have that. I can't.
Okay, so that's to be advised to me.
Well, I can
But
give you one name. I can give you one name.
I'm sorry about all that discussion. The membership of this board is changing so quickly that actually filling slots on the one subcommittee we have is proving very challenging. I can, however, confirm that Robert Peat will be one of the NHS representatives on the Audit and Performance Committee, and I will have to consult with the other 2 members to see if I can persuade either of them to join the Audit and Performance Committee as well. In terms of a chair for the Audit and Performance Committee, Councillor Stewart and I will have to discuss that once we have a chance to look at the membership when it's in a more stable position. We'll have to come back to the board to confirm that at the next meeting. Sandra.
Could I just ask, sorry, I'm a bit hoarse, could I just ask the paper regarding the update on voting members, there had been some discussion from the public partners which had been fed back asking for a slight change in the wording. I just wanted to check if that had been changed, removing the word appointment regarding service users. Has that taken place? So under non-voting members, point 22, the last paragraph. Further proposals regarding service user representatives will be brought to the next meeting of the board.
Sandra, thank you. There's a number of issues here. We've been working very hard to try and align the appointment of service user representative public partners, as we have discussed, to make sure that we have a proper cycle of appointments and alternate members, so that as we get into a more stable future, we will be building succession planning into this. And the reference in this paper is just a light touch on that, because we know that we need to think for the future. The way that things have been set up from the outset leaves us with a slight problem in that the elected members or the public partner members of the board essentially come to the end of their term all around about the same time. So in order to cover that, you'll see later that we're proposing an extension to 2019, and there was a typo in the original papers for the members who were due to complete their term, and that is part of the solution to getting us to a more stable process of election and succession planning. I hope that helps answer your question.
Absolutely, and as you're aware, we share your concerns
Indeed.
around continuity and the need for overlap. And yes, the concerns were just around the pedantics almost of the wording, and I guess the same. Aware there's been correspondence going back and forward over the last couple of days.
So all I can say is that in the update that I am to give a little bit later in the meeting, and in our intentions are to get to this more settled state, but because of the state of flux that we're in at the moment, and with all the membership, I would just ask that you would accept that we will happily work to get that settled between now and when we next formally report to the board.
Thank you.
Okay, if there are no other issues on IGB membership, just for the record, I will confirm that Robert Peat will be joining the Audit and Performance Committee, but that still leaves us with a couple of slots to finalise. If we could move on to the position of clerk to the board.
Thank you, Chair. As a number of colleagues around this table will know, I am retiring from Perth Kinross Council on the 30th of November of this year. And in order to provide some transition period, I intend to intimate my resignation as clerk to this board with effect on the 30th of September 2018. Obviously, it is a matter for the board to consider who they would wish to have as the clerk, and there's no obligation to take the clerk from the council, from the NHS, or any other body. It's a decision for the board. However, I am recommending that my very able colleague Scott Hendry takes on the role as the clerk to the board. I think Clark, just rename you. Scott has come to know the business of the board very well, and works well with all the different members of the board, and that would be my recommendation to the board, that Scott take up that role with effect from the 1st of October. So I would be in the role of clerk to the next meeting in September, and then Scott would take over, and on my very last day in office, which is the next meeting of the IGB on the 30th of November, I'll sit and wave to you all from the public gallery. But seriously, I'm recommending that Scott Hendry take up the post of clerk from the 1st of October, but that's clearly a matter for the board.
Is the board content to follow? Sorry, Eric.
Thank you, Chair. Firstly, congratulations to Gillian on her obviously very early retirement.
I notice you're not wearing glasses.
Congratulations on your retirement. I would just like to say, obviously everybody's leaving, and hope it wasn't something I said. But I would like to nominate Scott Hendry as your successor, Gillian.
I'm quite happy to second that proposal.
Thank you. Is everybody content then Scott should take over as clerk to this board? Thank you. And I would echo Eric's sentiments in terms of thanking Gillian for all the work that she's done in keeping us all straight, and I'm sure Scott will do an equally effective job in doing that going forward. So thank you very much, Gillian. If we can move on to item number 8, which is the redesign of substance abuse, I'll ask Rob to introduce this section of the meeting, please.
Thank you very much, Chair. So I'm delighted to introduce this item today. Many of you will be aware that the use of alcohol and other substances is a quite significant issue for the population in Scotland. And we here have 3 alcohol and drug partnerships within Tayside, and the team here in Perth Kinross also have an influence over our specialist inpatient services, and we have been working for some time to work with the other alcohol and drug partnerships in Tayside to modernise and progress this service. So I'm delighted to introduce to you Claire Mailer and Kenny Ogilvie, who will be presenting to you today on the substance of this paper. This is largely for information. Thank you very much. Excuse me, Claire, I'm really sorry. Is there a microphone that you could use? There we are. Thanks ever so much.
This is when things could go wrong. Is that better? Okay. So we're asking the IJB to note progress to date, note the proposed redesign in inpatient detox beds in Kinclaven, and also to approve the ongoing redesign of community-based substance use services. Given that we've only got a very short time period, this will very much be a high-level brief overview of work that's progressing. The report, as you'll see, gives background to the role of the ADP and the financial environment relating to alcohol and drug services in Perth and Kinross. The catalyst for change included funding pressures, the acknowledgement that existing arrangements were not fit for purpose, and there was a disconnect between the system of care, often resulting in a disjointed experience for the individuals who we were trying to support. And also the need to create an aligned model that delivers the ROSC that we're required to deliver on as required by the Scottish Government. So the next slide. Looks rather complicated actually, still up there. I think that is within your packs. The slide gives an overview of the project. It's a high-level project overview. It gives an overview of its aims and objectives, its intended outcomes, key work streams, and ongoing activity. The project was properly initiated in September last year, and between September and December we undertook a baseline assessment to enable us to understand how services are currently performing, how effectively services were delivering on outcomes, and this involved an analysis of current performance, finance and resources, feedback from staff and also from people who use drug and alcohol services. That then enabled us to scope out the project plan, its objectives, outcomes and key milestones. We held a business improvement event over a 2-day period in December, and that involved a number of key stakeholders and partners. And the main aim of that event was to engage partners in the redesign and to support us to shape it and identify how we were going to deliver the ROSC model. And throughout that we agreed key work streams, project objectives, timescales, and key milestones. That just gives a quick, here we are at the moment. This is like a map you would get in the town centre, so that's where we are. So, progress so far. The project's aims is to support the implementation and delivery of a ROSC, emphasising prevention and recovery. The main project objectives are to review and redesign the ADP delivery of services within localities, that's absolutely key, and reflecting the strategic priorities of early intervention, prevention and recovery. Clearly we need to adhere to the quality principles and care standards and also deliver a service that meets our legal and statutory responsibilities. We want to deliver a service that has the flexibility to respond to changes in demand at both a service but also at an individual level. So we need the flexibility built into any model of operation. And obviously we want to offer an efficient and value for money service, delivering improved outcomes for individuals, families and communities, and meet the ADP strategic aims of a whole family, whole population approach. So we've agreed 5 work streams that have been progressing. Kenny will talk about these in a wee bit more detail. Communications and engagement, the intention there is to improve comms within and between organisations, with people who need and use our services and of the ADP's role. Organisational development and training, that's straightforward, and as I say, Kenny will talk about that in more detail. Key has been the development of a performance framework, and I have to say we're working well with colleagues across Tayside to deliver a consistent performance framework which will really support us with identifying how service users are receiving our services and the outcomes that we're delivering on. Prevention is our 4th work stream, and obviously in underpinning all of this, we've literally been undertaking quite a root and branch redesign of processes that started at the BITE event that we had. Okay, so I'll quickly give you a quick overview of this slide here and then hand over to Kenny. The slide gives a visual of the recovery pipeline. Running horizontally across there are the stages. So the first stage is engagement, second is preparation, third is change. I see that we've not got these headings along these. The 4th is completion, and the 5th is reintegration. The tiers, those are the coloured blocks that are running vertically throughout the diagram, relate to the 4 tiers of intervention. So the first one in green, that's the first stage, early advice and information, very much provided by non-specialists, so that could be housing services and so on. The second tier in the yellow, that's the information and advice by specialists, specialist drug services. The third one is very much about community-based assessment and structured treatment. And the 4th one at the top, as you'll see, we've got conclave in there, and that's residential treatment. At the BITE, we took an exercise to map all existing services onto the pipeline, and it gave us a very, very good understanding across services about who does what, when, where, and when on a person's recovery journey, and gave us a very good overview of gaps in service provision and the areas of duplication. We knew from the baseline assessment that we'd undertaken that the challenges within the existing system, it doesn't fully or didn't fully operate as an integrated whole system approach. Services and service delivery was largely fragmented. It was absolutely clear that services were very much operating in silos. Any cross-service practice very much seemed to be more about relationships, good working relationships that had been formed on the ground, rather than structured or processes that had been agreed and in place. And teams were very much operating within their own section of the care pathway. And people were receiving services more that were available rather than those that they actually needed or wanted. Levels of lost contacts were high. There was a process of 3 missed appointments, and then you were sort of almost off, and that was leading to repeated referrals, which gave us, a number of concerns. So that process that we undertook at the BITE led us on to the next stage to start really with the implementation of the activity, which Kenny's now going to briefly describe to you.
My finger's not strong enough. Before we go on, under 3.1, it says an options appraisal was carried out early in 2017. Is this report available to read?
Yes, it is. We can get that to you, Maureen.
Where can we find that?
We have got copies on. I'm not sure if it's on the website anywhere, but we can certainly get you copies of it.
Can you do that, please? Yeah. Yes. And the second thing is an initial scoping paper is being drafted, so that's still being worked on then, is it? And that will be available to the scoping paper, will it? When is it likely to be completed then?
I'm just waiting to come on to say some of that in the presentation, but yes, we're still working on identifying the gaps.
Yeah. Thank you.
But certainly in terms of your first question, we can get that out to you, Maureen.
And I presume that carers and service users were involved in the
indeed they were,
appraisal.
yes, they've been involved throughout this process. Yeah.
So that'll be documented in the document.
Yes.
That's fine.
Yep.
Thank you.
Representation from carers and service users on our project team and on individual work streams as well, so they're fully involved throughout the whole process.
Yeah, we have service user and care reps on all of the ADP groups in terms of the redesign and the wider ADP strategy.
Thank you.
Okay, as Claire said, we had our bite in December, and one of the first things we did, based on information from that bite, was to improve our screening clinic on Mondays. We now have a multi-agency assessment and screening clinic on Mondays based up at Highland House, and that involves representatives from the statutory sectors and the third sector as well. Tayside Council and Alcohol, Gowrie Care are represented there. We also have links with bloodborne virus and also arrest referral. That provides initial information and screening for people when they come along, and it's followed up by a triage meeting where all the relevant professionals meet again, and they review the information that comes in through the clinic and from other referral methods to make sure people are passed on to the most appropriate service to support them. As Claire said, there were lots of examples of good practice that were happening before we started this work, but there were issues with people maybe accessing the wrong service at the wrong time. For example, people maybe going for intensive therapeutic support when they still had very chaotic lives. And what we're doing now is, to try and make sure if people have really chaotic lives, they're getting the support to try and get a bit more calm into their life so they're in a position they can actually engage with therapeutic intervention. After the bite in December, we then had a follow-up bite in June, just to just check on progress and just highlight further areas for development. And let us say that involved feedback from all the work streams that we had. The work stream leads shared that progress and just try and clarify what the next steps were. And this is the pipeline. Claire mentioned the pipeline before didn't have the headings. That has the headings on it. And if you see it from the left-hand side, that's referral agencies. Then it moves across to the screening assessment clinic that I mentioned, triaging, and then the various supports that follow after that, looking at the therapeutic intervention, and then the preparation for change, completion, and then reintegration. And you can see the box at the right-hand side, that is quite busy, but there is a logical flow through it. It is a linear diagram, but we have to remember, quite often people, they don't necessarily progress in a linear fashion. They can make sort of 2 steps forward, 1 step back, etc. So one of the important things is to try and make sure with the mechanisms in place where people can navigate through that pipeline and access the support they require at the appropriate time. And we're looking at things like sort of lead worker, they'll try and make sure that people with the most complex support requirements do have an identified worker from a particular agency who can help them navigate back and forwards. Communications is vital here. And again, you see the final box there, it's quite busy. There's lots of especially third sector organisations in there. I mean, the starting point is to make sure all those organisations know about each other. I mean, all the organisations on that pipeline, the bulk or all of their work is supporting people with substance use issues, but they don't necessarily know about each other, and they don't necessarily know if they're working with somebody, there might be a more appropriate agency to support them, or there might be the duplication going on that Claire was talking about. So communication is really vital here, to make sure that everybody on the pipeline is aware of all the other partner agencies on the pipeline and how they can help people navigate through and get the support they require at the right time. Like I say, that is still a work in progress. We then obviously have the wider communication issue to make sure that our more generic workers that don't necessarily have a primary substance use component to their job, like district nurses, sort of mainstream social workers, etc., they are aware of the pipeline and, again, know how to access it as required for the people that they're supporting. And again, those boxes there just give a bit more detail of what the different sections mean. Just if you look at the reintegration, again, there is a step beyond that. I mean, ultimately, we are trying to support people into the likes of further education, employment, etc. So, there is a box at the end of the reintegration. So we are tapped into employability supports, further education, etc. Housing obviously runs right the way through this. If people have adequate housing, that obviously reduces the chances of them relapsing. So next steps, again, we have a number of SLAs through the ADP with third sector organisations. It's just reviewing them and still making sure they're still fit for purpose in the brave new world of the ROSC that we're implementing. Identifying any current gaps in provision, and again, we've done a fair bit of work in this. There is some money, there's some debate as to whether or not it's actually new money, but there is £20 million nationally for substance use supports that's coming from the Scottish Government. So there are some resources that are coming our way. Gaps that we have identified initially is more trauma-based support for people in Perth and Kinross. We also have issues with improving support for people with substance use issues that have had their children removed, who are potentially at a high risk of suicide, etc. We also identified another couple of areas. Obviously, Perth and Kinross has a large rural hinterland round about Perth City. So we're looking at the idea of having not necessarily substance use, but well-being hubs that can move around maybe a day in each area. For example, maybe have a day in Perth City, a day in Blairgowrie, maybe a day up in Crieff or up in Pitlochry, Aberfeldy. And that's actually based on the model in Dundee, which moves down the various parts of Dundee. There's another couple of areas. We're looking at trying to implement a recovery community. This is based on work in Forth Valley, and that involves asking for volunteers who have a lived experience and actually providing them with a wage to be paid mentors, and then having sums of money in terms of participatory budgeting that we can offer up to communities to help provide supports for people with substance use and probably wider mental health issues as well in their local communities. So that's something we're looking at as well, and we may have identified funding to get that off the ground. Another area that we're looking at as well is support for short-term prisoners on release. Longer-term prisoners are tied up. They have statutory support in the form of social work on release. Short-term prisoners don't have that. And again, we know from drug deaths studies that people that have had recent incarceration in prison are at a higher risk of drug death on release as well. So that's another area that we're looking to try and beef up support for. I mentioned communication before. We're also working on training. Again, that's training at a range of levels. It's for people who specialise in substance use support, but it's also training for wider, more generic type workers. As Claire mentioned, trying to consolidate the prevention strategy. We do have a couple of posts at the moment that are working with schools and sort of wider wellbeing discussions, trying to reduce the chance of people being homeless and also falling into having substance use issues. We have a wider engagement event when we're going to feedback, hopefully on the finished pipeline and ROSC in October. And obviously this is linked. This is a community-based review that we're doing as well at the moment, but it's linked in with the current review of inpatient services up at Kinclaven. And that's the end of the presentation. We're now happy to take questions and also have some discussion about the frequency we'd like the ADP to feed back to the IGB in terms of the redesign, but also in terms of wider work that the ADP does.
Thank you, Kenny, and thank you, Claire. So could I offer the opportunity for people to ask questions of Kenny and Claire? Eric.
Thank you. I wonder if you could go back to the slide that shows the organisations involved in the process, please. Okay, no, not that one, but the one with all the names of the organisations.
That one there?
Yeah,
that one. That one?
Right, yeah. Yes, that one. Thank you. So I'm just trying to understand how labour intensive, how practical this whole process is, because on the left hand side, the left hand column, I think you've got 13 organisations, and on the right hand column you've got something like 20 reintegration paths, so to speak. And the key part of this process, as I understand it, is a meeting on a Monday morning at 9 o'clock in Perth. And I just wonder what, is that a chaotic Monday morning? Is it, yeah, I mean, I can't think of a more difficult time to get people who have drug and alcohol related problems to come into Perth and attend a meeting. So, and I just wondered what the attendance rates are of individuals who are in most need of help.
It's basically, it's a work in progress Monday morning. Like I say, this is a fairly recently implemented idea. Obviously, it's being reviewed. I haven't actually been along there yet on a Monday morning, but I'm going next Monday. Feedback so far is getting between 15 and 20 people turning up, actually physically into the building. But again, in terms of the triage, there's information that can come in via paper referrals from GP, electronic referrals, people phoning the access team at Pooler House. So there's a far wider, larger number of people actually discussed in the triage. It's once a week at the moment. I think it'll almost certainly be getting moved up to at least twice a week. Plus there are mechanisms in place. You know, if we get a crisis referral in through one of our health colleagues or through social work, there are mechanisms to respond to that as well. So it's not as if you've got a one window of opportunity only to access the services. The idea is to have a number of different access points and then a coordinated response, rather than people just going to initial organisations, if that makes sense.
Yeah, just a follow-up to that. Thank you for clarifying that. But so, what kind of numbers of people coming in through this route are you anticipating?
Like I say, it's 15 to 20 actually physically turning up at the moment. You can maybe add another sort of 10, 15 referrals on per week that are again getting discussed at part of the triage. One of the Scottish Government directives is what they're calling assertive outreach. It's actually going out and getting people that traditionally we found it very hard to engage with services. We are still scoping that out in Perth and Kinross. I certainly know our Angus colleagues are further down the road there, and that has led to a significant increase in referrals, which then you need more capacity to then process those referrals. So yeah, the numbers are likely to rise as we improve our access points and actually be a bit more assertive in our outreach. And then what we have to make sure is we don't have too many bottlenecks after that. We're not just going out promising people help that haven't engaged with us traditionally and then not being able to actually come up with that help. So yes, as I said, there is more funding coming. Most of that is for new initiatives, but we do have pretty serious discussions to have in terms of our current capacity as well. And that's the bit I was saying just about the review of our service level agreements. And we have to look at how we're investing our current statutory supports as well, just to make sure it is effective as possible, and we're increasing that capacity to try and make sure we don't have those bottlenecks.
Could I ask a question? You talked about silo working, you talk about the extraordinary number of touch points that you have with other organisations. It would seem to me IT should be absolutely central to what you're doing in terms of being able to connect the dots, reach people, give people access to websites if there are support groups and so on. How developed is the IT strategy? What are the constraints to making IT really work for you?
It's the old one of health and social care systems not speaking to each other. And again, we have health and social care professionals at the assessment clinic. At the moment, there's a lot of paper duplication of assessments. We don't have one system for progressing those referrals. That is something we are looking at, but something we're looking at wider in terms of right across the partnership. If we could get that nut cracked, that would be a significant improvement.
What's preventing that nut being cracked?
The two systems can't actually, well, when I say two systems, there's 2 or 3 health systems and one main local authority system. They don't currently speak to each other. The local authority system, we're actually in the process of retendering for that over the next few years because it's Swift EIS it's called. That's actually stopping anyway. So there is an opportunity there, and I believe Scotland Excel have been tasked nationally to look at this because there are a number of local authorities that currently use Swift, and they've been tasked to try and identify a system that does basically suit the demands for health and for the local authority. So it's partly technology. There are some areas, for example, I'm also involved in occupational therapy integration, and I think it's West Dunbartonshire, they did make the decision to move to the council system. So the health OTs actually moved across the council system and they just put all their information on there. So they're using that single system. So in terms of an all singing, all dancing, two systems that speak to each other, there are technological issues there. I suppose we could potentially bite the bullet and decide to move to one system, but there would be pros and cons of that for certainly health and social care. In terms of the communication strategy, sorry, we're also reviewing our website as well in terms of information on access and supports.
Okay, thank you. I would just say if there's any, in terms of developing that side of your work, I think it's a consistent theme as you know, an integration board is looking at disparate partners, and it's something we've got to work on because the economies of scale and efficiency are very clearly to be had. Can I take Helen first and then Jackie?
Thank you, Chair. Thank you very much, Claire and Kenny, for a really informative presentation and paper. I think the rationale for the service redesign is very clear, as indeed is the process, and I know that there are a number of third sector organisations and other stakeholders involved. I had a couple of questions. One was with regard to financial model. The paper mentions that continuing to deliver traditional models not financially sustainable, and I wondered, are there any distinct financial savings targets within the redesign project at the moment across the services involved in the ADP? I'll maybe take that question first.
At the outset, because of reductions in funding, there were financial targets. We have since had additional funding coming through, or we anticipate that there will be additional funding coming through from the Scottish Government. Kenny obviously mentioned the 20 million nationally, so we're still waiting to hear back from that. The Scottish Government is absolutely clear in terms of how that money should be spent in terms of delivering on the ROSC and the Scottish Government's strategic priorities. But it's absolutely clear in terms of high levels of spend are much further on in terms of the reacting to rather than the early intervention and prevention. So the model and the approach is actually to sort of, if we can, shift resources to earlier intervention and prevention, and then prevent what can be very high spend much later on.
Thank you, Claire. And my second question, just briefly, was around social prescribing. It was highlighted in the report as a good practice example, and I wonder, is the learning from that specific piece of work now being brought into the new social prescribing posts? I think that'll be quite critical in terms of helping to support some of the disconnects within the pipeline that you've been talking about.
Yes, is a short answer to that. As you rightly say, we did have social prescribing posts working very closely with as part of the drug and alcohol team, and they were highlighted as an area of good practice in the recent care and spectra audit. Unfortunately, we didn't have the funding to continue those posts, so they've now stopped. But we have got funding for more generic social prescribing posts, yes, and we're making sure the learning from that substance use social prescribing is transferred across into those wider social prescribing posts. So yes, that won't be lost.
Thank you, Kenny.
Thank you, Chair. It was really just to provide a piece of information in relation to your question around IT, and that at the Council's meeting on Wednesday, there was approval of £2.7 million to support the replacement of SWIFT. And we've had subsequent discussions around how we're going to take that forward. And as Chief Social Work Officer, I will be the senior responsible officer for that piece of work, involving members of staff across the Council and the Health and Social Care Partnership. So we're hopeful that we will have a system that might better suit the needs than it does at present.
Thank you, Jackie. I'm aware that our guests have to be there by 10:30. Jim had a question. Was there anybody else?
Anne as well.
And Anne. So Jim and then Anne, and then we'll close the discussion.
Yeah. Probably more a comment than an observation. I think actually I'd like to commend the team on their approach in respect to service transformation and redesign. I think it's exemplary. I think your ADP BITES approach, the self-assessment and it coming together, very comprehensive. I think the other thing I would comment positively on at this stage is the indication or the intent to move to develop a performance framework, which I think is absolutely critical. So I think well done.
Yes, this all sounds very exciting, but can I ask a question about reintegration? I noticed there you've got an awful lot of charitable organisations. Will these organisations, have they all signed up? Will they be able to cope with, the referrals that they might get? And if they can't, what support would be there to help them?
I mean, again, in short, yes, they have all signed up. I mean, they are actually currently undertaking that work. The plan is to try and coordinate it a bit better. I mean, each of them are funded probably from a myriad of different places, and that funding is almost always fixed term as well, so that will be an ongoing issue, trying to make sure that they do have adequate funding and support. I suppose from our end as an ADP, we just have to try and keep a track of things, and I mentioned bottlenecks in one of my previous answers, is just make sure, if because of the pipeline, and hopefully at the sign that things are working better and more coordinated than they are, if people are starting to see an increase in demand for their supports that they can actually meet, it's up to us to try and make sure that is identified and try and address it as best we can.
That's good, thank you.
Thank you very much. So we have a number of conclusions and recommendations to see here. First of all, that we note the progress to date. We note the proposed redesign in patient detox beds at Kinclaven, and that is a separate project which has been looked at in parallel. We approve the ongoing redesign of community-based substance use services, and we instruct the chair of the ADP to provide a further report on both reviews to the IJB at least in June 19. Could I also just add, as we do that we're going to ask that the presentation is made available, because some of the printing is quite small and people might like to see that in more detail.
Maureen, you're squeezing under the wire. You're squeezing under the wire.
Oh, right. Just to elaborate on that a bit more about what Anne brought up there, the funding, you know, for the third sector and these charities that are picking up a lot of the work in the community. As you say, you know, it's not ongoing funding, you know. Is there anything being done to address that? Because it's got to be recognised that, you know, these charities and the third sector are picking up a lot of the work, and I feel that there should be, you know, that it should be looked at, you know, in the broader picture, maybe not just even in Perth Kinross, but it's happening everywhere else, that something needs to be done, you know, to fund them adequately, you know, to do the services that they've been tasked with. And just another thing on the first point that you were talking about this thing on a Monday morning, could you elaborate a wee bit more on that? Is this something that service users can actually come along to?
Yes. Like I say, information can come in a myriad of different ways, but people can actually present themselves. Yes.
Yes. Right. And is it well known in the in the drug and alcohol community that this is there?
Yes, like I say, we have made it known that the clinic exists. That is obviously still a work in progress, because it has only been up and running a few weeks. But yes, is a short answer.
And where is it?
It's up at Highland House, the retail park. Yeah.
Right, thank you. The question about the funding.
Well, the question about the funding, I mean, in terms of the ADP, obviously we have a pot of ADP money, and we do have service level agreements with third sector organisations. So that is done, you know, through service level agreements that run for a number of years. It's often 2-3 year funding rather than just short one-term funding to allow people time to actually, you know, retain staff, train staff, retain staff, and actually provide a decent service. The ADP doesn't have the resources to fund all of the charities in the final box. That requires, bigger picture support.
Because we've actually just really employed 3 social prescribers, yeah. And, you know, they have to know what they can refer people to, and if it's going to be ongoing, or is it just a short-term thing, you know. So, you know, it really needs to be looked at, you know, what's available in the community, and that they have the funding, you know, to carry on doing what they're being asked to do, so.
Maureen, if I can just come in there. The funding that we get significantly from the Scottish Government to fund the ADP activities, I mean, we need across Scotland, and we have, the Chief Financial Officer has been putting pressure on the Scottish Government to give long-term commitment to funding streams, so that we can do exactly as you're describing, to make long-term commitments to fund voluntary and third sector services that we are planning to rely on as part of service redesign work. And it's pressure that's being put on at national level to try and tackle exactly the concerns that you've raised.
Further to your question about the regularity of updates, I'll discuss that with you outside the meeting, and we can look at what the most appropriate intervals would be in order that the board is kept up to date, if that's okay.
I'd just like to say thank you very much for a really good presentation, and I would echo Jim's comments, I think, in terms of the quality of work that's being done. We certainly look forward to seeing you no later than June of next year, and as Rob said, on the performance issues, we'll leave the experts to discuss the appropriate mechanism for that. Thank you very much.
Okay, thank you.
Colleagues, we now move to item 9.1, and I need to point out the change to the integration scheme. You'll see on page 43 there's some tracked changes, and all this does is it updates the integration scheme to include the requirements under the Carers Act. So this is a formal change that every IJB in Scotland has had to make. It's been to the Scottish Government and back, and it has been approved by the Scottish Government. So it's just for our noting.
Could I just ask if the Carers Act is going to be on the agenda of the IJB soon?
Maureen, I can't remember right now, but obviously it's a very fundamental part of our obligations, and we can certainly discuss that as we plan the agenda for forthcoming meetings. We're just at this point in time, you're going to hear about this a little later, we're going to be putting a structured forward plan for all agenda items so we can make sure that that is included.
We're moving into the finance section now with Jane, Jane and I discussed beforehand that there's a more logical flow to these papers than we've put in the agenda. So I think, Jane, if you could start by reminding people what the flow is that we'd like to just take the papers in, and then I'll pass them to you.
Thank you, Chair. Yeah, the readjusted order is that we will take the 2017-18 financial position first. We will then get feedback from the Chair of the Audit and Performance Committee on the meeting that took place earlier this week. That will then take us into the draft unaudited annual accounts, and we'll finish up with the 18-19 finance update. So if you bear with me, so in terms of the 17-18 financial position, we've reported to the IJB at every meeting on the forecast position for 17-18, and now we can report on the actual outturn. The actual outturn is absolutely in line with the previous forecasts, and overall IJB is reporting an underspend of 1.4 million. That splits down into two or three key areas. The first area is the significant underspend on social care, which has been reported at all of the previous meetings over the course of 17-18, driven by significantly non-recurring issues, accelerated savings, slippage on the use of transformation funding, and other non-recurring issues. That is offset significantly by a £1.7 million overspend on GP prescribing and a share of a £1.4 million overspend on inpatient general adult psychiatry. Both of these issues, prescribing and inpatient mental health, significant challenges in terms of balancing the 18-19 financial plan, which I'll come on to shortly. Happy to take any questions.
Sorry if I seem to be hogging this, but we went through the papers quite extensively, in the middle of the week, and we've prepared some questions here. You see on page 21 of the report, the second last paragraph, sorry. All right, am I jumping the gun here? Page 21, yeah. So
we'll carry on.
Yeah, just carry on. Thank you.
Any other questions? No, I'll carry on. Okay, so we'll now hand over to Chris.
Thank you. As you said, the Audit and Performance Committee met on the 19th of June. With regards to the action points update, performance reporting, that's an item on today's agenda for performance framework for older people's unscheduled care. The Clinical Care and Professional Governance Progress Report. There's also a full update on the recommendations on today's agenda. The Governance and Accountability Arrangements. Work is ongoing, and a fully worked up paper will be brought back to the IJB in September once the Chief Officer has had a formal agreement between the NHS Tayside and Perth Kinross Council on their governance and accountability arrangements, and hopefully that will be fully signed up by both parent bodies. Delayed discharge forms part of the wider performance reporting arrangements. We did get a view of the current statistics and felt that they weren't fully updated. We couldn't put them against anything, so we've asked for a more clearer, detailed report to come back to further committee meetings. Transforming the Governance Action Plan update. The Chief Financial Officer explained that effectively that was the last update for this year's Governance Action Plan. It will be superseded by a new action plan with a different set of governance priorities, even though some will be overlapped, but they'll be brought forward, which requires some further work. The chair of the IJB advised that he will take this forward with the chief officer, and there was an issue regarding training and development of board members when we'll report back to the next committee meeting. And it was also mentioned that we should probably have a reporting and performance review of board members. How that's going to take place, that will have to be discussed as well. Internal audit, the recommendations, there'll be a report taken back to audit performance on a regular basis. And of the internal external audit recommendations, there are 7 that were overdue. One of these relates to a requirement for clear performance framework, which is on today's agenda. 3 related to the clinical care and governance, and 3 were on delayed discharge. There is a programme of management improvement plan in place, and Louise Beveridge is doing a piece of work on the pathways. There was a discussion on the clinical care governance and the framework which is currently in place, and the Audit Performance Committee decided that remit for the current local clinical care governance forum should be redesigned and be a subcommittee of the Audit Performance Committee. The membership and leadership of this group should be confirmed, and the discussion with the private and third sector to be considered as well. There was also a discussion as to whether the name should be changed to encompass what's being proposed, and the Chief Officer will progress this and report back to the next Audit and Performance Committee in September. There was an update on the strategic risk management. The Transforming Governance Action Plan sets out a refresh of the risk, and a set of risk workshops is to be committed. Now, we've already had 1, and there's another 2. They were postponed, and that was to get further detail on what was required. And I believe the workshops have now been arranged for early and mid-August. The IJB complaints report, these relate to 3 levels: health, social care, and the IJB. And there's only been 1 complaint in relation to the IJB, and concern processes on decisions and the format of the meeting. Majority of the complaints were concerning prisoner health care, which is to be expected. It's proposed that reporting on complaints will come through the committee regularly or via the subgroup of the committee, which has been proposed, which will replace the Clinical and Care Governance Forum. There was a query on how compliments are captured, but we also looked at the fact that there were cautions raised on how these are delivered to the committee. It could be skew the figures a bit, so we'll have to look at how that's reported. We also have the NHS Tayside Clinical Care and Professional Governance Annual Report. We noted the report, however, we also noted that it didn't really tell us anything. It was hard to understand, as it was just a list of what came before their committee. The Chief Internal Auditor's Annual Report and Assurance Statement for 2017 and 18. There was discussion on the recommendations, and as you heard at the beginning of this meeting, the minutes, it was noted that the minutes were minimalistic and didn't provide a record of the discussions, questions asked, and the assurances of the IJB and the Audit Performance Committee. Committee and Democratic Services agreed to take these recommendations on board. And it was also noted, as was said at the beginning, that the IJB is now being recorded. Of importance is that the conclusion of the report from the Chief Internal Auditor is that reliance can be placed on the IJB's governance arrangements and the systems of internal controls for 2017 and 18, and the Chief Internal Auditor has not advised the management of any concerns around the consistency of the government statement with information he is aware of from his work, the format and content of the governance statement in relationship to the relevant guidance, and the disclosure of any relevant issues. We then appointed Tony Gaskin as the Chief Internal Auditor, and FTF as the IJB's internal auditors for 2018 and 19. The annual accounts, you will get the unaudited annual accounts for 2017-18 next, as well as the annual governance statement. Also of importance was the annual performance report. This is required to be published by the 31st of July. It's currently in a draft version and is being finalised. Today will be instruct the Chief Officer to circulate the report for comment, and an additional Audit Performance Committee will need to then be called before the end of July this year. Discussions took place as to how that meeting would be formed, whether it would be a round the table meeting, whether we would get the report by email, or whether we'd do it by a virtual meeting. I think it was agreed that any of those forms would be satisfied, as long as that all members were able to put their comments forward on the report. The performance framework for older people on unscheduled care. We noted a proposed indicator set, the development of the programmes of care, and the setting of targets and monitoring will be the responsibility of the Older People on Unscheduled Care Programme Board, and they will report to the Audit Performance Committee which will move a qualitative and quantitative approach, and 6 monthly reports on performance will be received. Finally, for noting, Jim Fowlis advised the Audit Performance Committee of 2 recent Health Improvement Scotland inspections which took place in HMP Perth and PRI. There were a number of concerns and issues highlighted, and for HMP Perth, Health Improvement Scotland is satisfied with the immediate actions which have taken place, and an action plan will be submitted by the 2nd of July. So a lot of the points they brought up have now been sorted out. Concerns were around care planning, medication administration, documentation, and we will get a formal report back in August, September. For PRI, there were some extremely good examples, including the meal times, data for patients, improvements suggested in care planning and food preparation. And also it was noted that further work is required in terms of the medics completing documentation. That's the end of the report from the meeting, Chair.
Thank you, Chris. Are there any questions for Chris on that?
Thanks very much for a very comprehensive update, Chris. Can I take you back to the section on complaints? Could you firstly recap the numbers and then just let us know what time period that those complaint numbers were over?
In terms of the actual IJB, there was 1 complaint, and I'm not quite sure when that was.
That was subsequent to the March meeting.
Oh, that's right. It was to do with the decision on the care homes. And I don't think we had a figure for the prisoner complaints. We're just that there is a large number, and that's to be expected.
I can furnish you with that information.
Thanks. It's just that if I recall correctly, we adopted a new complaints policy in August last year. I would have, the way it was structured, I would have anticipated complaint levels to be higher because we were capturing things which were not formal written complaints, but comments as well that should be treated as complaints. I would have just expected it to be higher. So, but seeing the detail of that would be great. Thanks, Rob.
Sure, Councillor Stewart, I'll be very happy to make sure that the detail of that is available at subsequent meetings.
Okay, Jane, we'll go back to you on.
Okay, moving on then to the unaudited annual accounts for 17-18. As Chris has indicated, the draft accounts came forward to the Audit and Performance Committee earlier this week. In parallel to that, the Audit and Performance Committee considered the draft governance statement. Its consideration of both documents was supported by the internal audit annual report, which, as Chris has outlined, gave support to the detail in the annual governance statement and the level of control and assurance in place in the IJB. The Audit and Performance Committee also approved the draft unaudited annual accounts. Just to summarise the annual, one thing I need to highlight for the record is that there is an error on page 74 of the papers at paragraph 3.2, which should read 1718 instead of 1617. I should also note that we have had early discussions with our external auditors who will begin the formal audit of the accounts after sign-off of the draft today, but they've given early indication that on page 95 for the consolidated income and expenditure account, we have separated out GP prescribing as a separate expenditure line, and because we've done that, we need to put the word restated as part of the income and expenditure account. So we just wanted to make the IGB aware of that. So two slight amendments to the covering paper and the draft accounts themselves. In terms of the draft accounts on page 76 of papers, we can see how the annual accounts split out into the management commentary, the statement of responsibilities, the remuneration report, the annual governance statement and the annual accounts themselves. Colleagues will have had an opportunity to read that. On page 82 of the accounts, what we can see is that a description of the how the 17-18 annual accounts tie into the underlying performance of the IJB, which I've just reported to you in terms of the 17-18 outturn report. We are reporting an overspend of 1.27, an underspend of 1.279, sorry, I'm getting my figures mixed up here, an overall underspend. There are different components to that. The risk sharing agreement means that the overspend on health budgets is offset by NHS Tayside, allowing us to achieve break even. The underspend on social care budgets has been taken back by Perth and Kinross Council and will be carried forward in a reserve by Perth and Kinross Council into 18-19 and will be passed back to us as part of the 18-19 budget settlement. So overall, we have a break-even position reported in our INER account. We have in 17-18 we had a level of reserves that have all been fed in to the 17-18 financial position, and we have no reserves to carry forward into 18-19, and the balance sheet reflects the movement on the reserves with the IGB not holding any other assets. And I'm very happy to take any questions.
Any questions for Jane? Maureen?
On page 10 we have at the last paragraph before financial outlook, says that both areas, that's GP prescribing and inpatient mental health services, are undergoing a significant review and transformation with plans in place for 2089 that you see significant reduction in levels of spend. Now, that's for 2018-19. So going forward, that reduction in levels of spend will be used otherwise in the community. Is there a guarantee of that?
The financial plan, which we'll come on to, Maureen, shows that there are significant level of underlying cost pressures within the inpatient service. That's driven by locum costs, nursing costs, and a level of undelivered saving that's been carried forward in future years. All services require to make efficiency savings because all pressures incur pressures. So the inpatient mental health service has a level of underlying overspend that needs to be addressed before we can consider reinvestment of funds into the community. Once we've brought financial sustainability back to those services, that's the point at which we can consider shifting the balance of those the current budget into community-based services. But we need to bring a level of financial balance to the services before that can be a consideration.
Right, and then a bit further on there we've got about the recurring settlement for 2018-19. Could I ask what the non-recurring, I'm switched on, what are the non-recurring funding and what are the agreed projects that you're talking about here? talking about agreed projects in the last paragraph there under financial outlook.
We'll actually come on to that as part of the financial plan paper. I'm happy to take it here. Well, the inpatient mental health financial plan was discussed in detail by the Budget Review Group at its meeting last week, where we went through the cost pressures that the service are facing, but the significant transformation plan that is being taken forward. That transformation plan consists of a number of parts. At the core of it is the agreed transformation that came to this board in January, and within the transformation of inpatient mental health services, there's an opportunity to drive significant workforce redesign that will help offset a number of the pressures that we're facing. As well as the savings that come out of the agreed transformation, there are a number of other work streams that are being taken forward to bring financial balance to inpatient mental health. That includes review of medical staffing, it includes review of how we are special observations and the policies around special observations and how that impacts on our nursing costs. It links to the discussion in terms of the ADP review, because part of what we will look at is the inpatient ward at Kinclaven and the model and delivery of service, and whether there's a more efficient model in terms of potentially shifting the balance of care in terms of our inpatient drug and alcohol services. So there's a wide programme of transformation that will help bring financial sustainability to inpatient mental health services.
Thank you. And I don't know if I'm jumping the gun going on to page 21. Am I okay to bring in something on page 21 at this stage?
Of course, yeah.
Okay. In the last paragraph, under review of inadequacy and effectiveness, could I ask that you identify what are the weaknesses identified? You've got that there are weaknesses, some indicate some weaknesses in the internal control environment. What are these weaknesses? And also, what is the level of impact that this might have on service users and carers?
The internal audit annual report that Tony Gaskin brought to the Audit and Performance Committee, where this is looked at a level of detail that that's the reason we have the Audit and Performance Committee, so that it can take the time to review these issues. But the conclusion of internal audit, that while there are weaknesses in our that we've recognised in the action plan that we brought forward to the Audit and Performance Committee to address some of our governance issues, which you would expect as a fairly new public sector body, that there was no material weaknesses that would impact on the annual accounts. So there is nothing of significance.
But none of these weaknesses would impact on carers or service users because of identified weaknesses here?
No material weaknesses.
No. And the other thing is, you mentioned about internal audit, but how often is an external audit done?
The external audit of the annual accounts takes place on an annual basis, but obviously there are other external reviews that Chris has referred to in terms of the review of the prison service, the review of PRI. There are a number of service external reviews that go on throughout the year, and these will come forward to the Audit and Performance Committee as part of their scrutiny role.
Talking about the external audit of the accounts, in general.
Annually.
Annually.
Yeah.
Thank you.
Thanks.
Okay, if there are no other questions on... sorry.
Thank you. Excuse me. Thank you, Chair. I just wanted to try and summarise the financial position that we're in ahead of looking forward to future years' budgets. And I just wanted to ask Jane, just in a couple of sentences, please, just for the benefit of those that have not spent the last several months engrossed in the complex finances of the IJB through the Budget Review Group and the Audit and Performance Committee. To clarify, because you said at the start of your report that a break-even position overall was achieved in 17-18, which it was, But can you just in a couple of sentences, again, just reiterate how that was achieved so that there's a wider understanding of the pressures that we're currently facing going into future year discussions?
Sorry, just bear with me till I get to the relevant section in the report. Yeah. Okay. Thank you, Eric. Just to be absolutely clear, we had an underlying overspend on our health budgets. That overspend was driven by GP prescribing and by our share of the overspend on our inpatient mental health services. We are in year 2. 17-18 was year 2 of our 3-year risk-sharing agreement with both partners, and what that means is the NHS side take the responsibility for passing out additional budget to offset that overspend, which allows our health budget to break even. For the social care budget, we reported an underlying underspend of 2.6 million, largely, almost wholly, a non-recurring underspend. There were 2 options with that underspend. We could have been allowed to retain that. The integration scheme allows that. However, the decision was taken by PKC to take that and retain it in its own reserves and to carry that forward into next year as part of the Perth and Kinross Council reserve.
Thank you for that. Yeah, I just wanted to make that clear, and just you know, in amongst all the information that's coming out, it's just that clear statement of where we're at. Thank you.
Okay, I think before we move on from this paper, the board is under the conclusions and recommendations. The unaudited annual accounts required to be submitted to the Controller of Audit by the 30th of June 2018, subject to approval by the IJB and authorization by the Chief Financial Officer, and it's recommended the IJB authorises the Chief Officer to sign the unaudited annual accounts. Are we content to follow both those recommendations? Okay, thank you.
Okay, the final report brought forward today is the look forward to 18-19. I thought it was important, given the level of risk, financial risk that we are facing, to bring forward to the board at this stage before we go into the summer months to give an update on the financial plan and to give an update on the level of financial risk that we are facing in 18-19. So the report notes a gap in the financial plan of 920,000, and what that means is that if nothing else changes, we will forecast an overspend as an IJB of just under £1 million. That ties back to the conversation that we've just had. That is largely in relation to a much reduced gap on GP prescribing. I think the gap is now sitting at just over 400,000, so a significant improvement forecast on our GP prescribing, but still a gap, and a continued share of a still significant gap on inpatient mental health services. So these are the key issues that, if nothing else changes, we will overspend because of those 2 areas. However, what the paper does do at Appendix 2 set out a range of issues that are very likely to impact on our financial position in this financial year. I don't want to go through these in detail. You will have had a chance to look at those, but there are a number of large material items which I'll just touch on. The first is in relation to complex care packages. And our complex care costs are incurred both in social care and in health. On the social care side, we have a very significant unanticipated pressure emerging in relation to complex care packages. We've done a deep dive into that. That was shared earlier this week, and there is unquestionably a level of unanticipated level of complexity of a number of complex packages that is significant, giving rise to a large part of this pressure. And we now, under the integration scheme, need to have discussions with Perth and Kinross Council colleagues about how this emerging pressure may be taken forward. The integration scheme sets out provision for emerging pressures to be discussed in year with the relevant parent body. So we would seek to do that. The other key driver of the level of risk that we face is in relation to one of our very significant savings plans, and that's our intention to reduce 84 care home placements through investment in the community-based services and in particular carer support. There has been a level of slippage in getting the carer support that we want in place in the community. For this year, there is a significant high risk that the level of savings on that Shifting the Balance of Care project will now not be delivered, and that's £775,000 worth of saving that there's now a high risk around. That's the two. The complex care and shifting the balance, our savings scheme, are the most material issues from a social care budget perspective. From a health budget, we've still got a level of underlying kind of risk around GP prescribing, whilst we've got a plan that significantly reduces the level of gap. Those who have been close to any of the discussions on prescribing will know that there are so many factors nationally and locally that can change the position on GP prescribing. I'm content as Chief Finance Officer that we've got really much improved monitoring place that will allow us to pick those things up far more quickly than previously, and Hamish's involvement from a clinical perspective in understanding what's going on and having early warning is making a big difference. The other health issue is in relation to complex care. Also, the complex care budget for the health contribution to packages has not been devolved by NHS Tayside. NHS Tayside have at this stage indicated that there are no funds to cover those costs, and therefore there's a significant risk attached, and that's just under £500,000. So I think, just in conclusion, we have £1 million gap in the financial plan, but we have almost in total a further £3 million of high risk issues that we will now have to have some very imminent discussions with both parent bodies to discuss how that's going to be managed in the year.
Thank you, Jane. Any questions on Jane's report there? Eric.
Thank you, Chair. So, again, just to try and distill that down to the key messages here, if you don't mind, Jane. What we're saying is that at the start of the financial year, we are forecasting a £920,000 shortfall. There are in-year risks that have emerged that significantly increase the likelihood of a shortfall in 2018-19, and as we're going to come on to understand, for 2019 going forward, these pressures are only going to increase. Would that be a fair summary?
Yes, it would.
Thank you.
And for reassurance around for members in terms of careful planning for 1920, we are bringing forward our 3-year financial plan to the Budget Review Group next Friday for a detailed session to not just look at the 18-19 position, but to look at 19, 20 and 21, the level of additional pressures that we face and the emerging further gap for those 2 subsequent years.
Thanks, Jane. You mentioned the 84 care home placements and level of slippage in getting the level of support to carers in place. Just was looking for a little bit more detail around that. Is that about the timing of the interventions and other investments in support being in place, or is that about the interventions not having the desired level of impact at pace? Just to get a bit more of a feel around how recoverable or not in time that aspiration for that area of transformation is.
I I think the honest answer to that, there's both. I think in terms of the pace at which the project got started is one. The second thing is the ability to recruit the workforce that we're looking for to put in place some of the services for carers is the same workforce that we're looking for some of our other services where we know there's recruitment and retention difficulties, but there's probably also a wider risk. It would be easy to sit and say this is simply just slippage and a timing issue, but I think there is a question mark about whether or not we will actually be able to take out the level of care home placements that was predicted, that the level of impact that the investment may have may not give us the impact, as much of an impact as expected, and taking out 84 in total may not be achievable. So I think it is a bit of slippage for the reasons I've outlined, but I think we need to very carefully, and the Audit and Performance Committee has asked to take a real close eye on this to make sure that we're simply not taking out 84 whether we've actually delivered on the ground sufficient additional community services to make that real and undeliverable.
I would just make an observation about the care at home. There's an underspend in care at home, and this is put down to recruitment rather than being able to spend the money. So I'd just like to say, how do we ensure people's expectations are being cared for at home? You know, if recruitment is an ongoing problem, like, you know, and that people are expecting to be cared at home now.
Maureen, thank you very much for your question. You raise a very, very good point. Could I use the word supply rather than recruitment? Because it's about the number of people who are available to come forward for work like this, that we are existing at the moment in an area where unemployment is very, very low. It's less than 1%. We have competition between the agricultural sector, the hospitality sector, and very recently too, colleagues in children's services are now looking to enhance their support in terms of improving their carer support. Chief Social Work Officer may be able to comment on that in detail, but we're all looking in the same area. So we know there's a huge growth in the frailer older population. We are already seeing a significant shift. So some of the problem is that we've actually been quite successful. And you know, last year, for instance, we planned for 600 hours of additional care. We actually delivered 900 additional hours of care, but what was required was something over 1,400 additional hours of care. So this is absolutely about supply and demand of the right type of people. So we're beginning to think very carefully about how we attract people into health and care from college, from school, to look carefully at how we could attract, say, people who are in early stages of retirement, Gillian, just in case they wanted to come back and give us a little bit of help with this type of work, because it's a success. It's a success story. People are living longer, healthier, and that when they do get to the point where they need care, we know that they're needing more complex care. So that then ties into the comment that Jane was making about it being more difficult to maybe remove all the care packages that at the outset we thought we could.
Yeah, but I'd like to just say that, you know, that's going to be a problem with the finances as well, because you lure people back from retirement, like, you know, then, you know, it's the same in education, you know, teachers coming back, supply teachers and that, and the cost is much, much higher than people on the ground. I think what we need to do is to try and see if we can get them to stay longer in the first place, like, you know.
Thank you, Maureen, and I'd be very happy to talk to you offline, because this is clearly a dialogue around how we are going to work more efficiently, effectively with carers in Perth and Kinross, almost to reframe what has been expected in the past, to look at what can be done in the future, and to work that through together.
And just another point here, which links up with a paper later on your paper on the SDS, that the uptake on SDS seems to be less in the rural areas. Is that because the option 1 is not being offered in rural areas? And what is the breakdown of the 19% that's quoted in your paper later on there?
So I can't give you the detail on that, Maureen, but I know that we're in the same area of conversation here, in that it doesn't matter which of the options for self-directed support you might choose. It's only as good as the supply that is available. And again, I might defer to my colleague who understands the detail of the different options and how that works. But the bottom line is, if we can't get the people because they're not available to us, it does make things more difficult. So therefore we have to think carefully about what the alternatives are to keep people safe and well cared for in their own homes.
Thank you.
I've got Colin, I've got Cesar, I've got Eric. What I'm going to suggest is that you all put your questions back to back before there's a response. I then think we've probably earned a coffee break because I'm probably in breach of good meeting protocol. Am I not true? Yes. Okay. So I don't want to be any further in breach than I can. So we'll take those last three questions bundled together as one, and then Jane or Rob will respond as appropriate.
It was a couple of questions. Thank you, Chair, on the care home placements issue for Rob, and one on GP prescribing as well. Discussions with colleagues offline have suggested that our care home placements or the availability of care home placements could potentially be an income generator, particularly in respect of step-down care. And I just wonder if we could be assured that either that has been fully explored or it is being fully explored in terms of rather than it being a drain on resources, it could potentially be a depending on how the accounting was done, it could potentially be a positive contributor to resources for the IJB. And also, from speaking to people on the doorsteps as politicians are want to go and annoy people in their own homes, I occasionally get feedback that those who are carers, either professionally, well, no, let's stick to professional carers, feedback that professional carers are increasingly leaving the profession due to the pressures they feel. So in terms of trying to bring people back in, if you just wanted to cover how difficult that is. In terms of GP prescribing, when I had my first induction over a year ago as a proxy member of the board, GP prescribing was mentioned as probably one of the key concerns at that time. So I just wondered if we could get an update on the specifics of the action plan, just a verbal update on the specifics of the action plan to address that issue, because every time we look at financial statements or concerns around the finances available to the IJB, GP prescribing is at the top or second top of the list.
Very briefly, and this probably is a reflection of, might be a very naive question, but you mentioned that there were not going to be reserves and that the underspend is going to be kept within the council. Would that be a possibility of being factored into the risks for this coming year in order to minimize them?
Yeah, one final question. Thank you for giving me a second opportunity, Chair. Just following on from the comments that Rob has made on the supply side of staffing for the care at home, etc. Would you agree that one of the critical factors that are involved here is the impact of Brexit before it happens, and will that be an increasing problem post-Brexit?
So may I start, and I'm going to start with Councillor Stewart's question. The first point you made was about income generation for step-down care. So if I could just take it in a more broad response to your question. One of the things in Perth City in particular is that we don't have a community hospital. So the whole question about how we design I suppose the bit that's between acute care and being ready to be home is extremely important and is our focus. And within some of the work you're going to hear about a little bit later, we're going to be working in what we call care groupings or care streams. So we've devised a care grouping around older people and unscheduled care. So that takes us into the territory of thinking about the whole journey from before you ever need anything all the way through acute care and then back home. And as people age and as they become more dependent upon support of one type or another, it's not a quick switch on, switch off relationship, and it's very much around the assessment of every individual to look at how well they can survive, function, and flourish at every point along that journey. So you raise a very broad question, and the idea of income generation is one thing that we could look at. However, that would assume that we had a property that was ours, that we could then charge a premium that would be above the costs of running that facility, but there is no reason why we can't look at that as a principle. What we are thinking about, though, in our deliberations around the new model of care that will come for Perth and Kinross, and again, if I could refer to the work that's been done in Angus, which has been now nationally recognised, they have a new model of care where they're looking very carefully at the design of what is required for the emerging population to make sure that we have the right distribution of different types of care. So if I could just move to one side, the supply issue, which is going to be a challenge for us, and we need to work within that. There's very definitely a need for us to find the right model for this step-up, step-down care, and almost what might have been in the past called convalescence, as people are getting ready to go back to independent living, and to refresh that in a way that's both modern, sensitive, and appropriate to people. And then with our large geography, we've got to think carefully also about how we would place that. So I hope that covers that issue. The very specifics about income generation, I think we need to work up more detail and see what you're thinking. On the second issue which you raised, which is about the doorstep opinion of people seeing this as very difficult work, we recognise that. And the whole purpose of the Carers Act is that it brings to us as an IJB the responsibility not only to think about the service user, the person who is receiving directly the interventions that we can provide, but it's for the very large and often unsung population of people who take care of people who have a range of different needs, very complex as they are. And therefore, whether it be in the paid sector or whether it be people who are looking after their own families, relatives, friends, etc., we do have a building responsibility around this support to carers. So if we're looking at the supply side and the reputation issue, this is back to the same point as we were discussing earlier about trying to raise the profile of this really important work. This is really worthy work. But it's that thing about making sure that people in the younger age group see this as an attractive career option with prospects. So we've already begun speaking with local educational institutes. We will be talking with schools, and we'll be looking at new pathways and trying to devise pathways that would take people through some experience in health and care. And if they want to go on to train in a profession, or if they want to develop their own future, finding the ways in which we can create those links. So this is about an alternative way of building the workforce. And of course, that will help us not only with a supply of people who can provide generic support, but it'll also be a pathway into the careers where we also suffer some shortages. And we can see with the demographic changes in Perth and Kinross that are coming, that over the next 20 to 30 years, the working age population is pretty static, but the aging population has just been projected to go up by 100%. The last time it was measured in 2014, it was 70%. So we can see that this is a huge challenge for us in the future, and we need to address it right now. Could I just pause at that point and ask Hamish to answer the question about prescribing, and then Jane reserves, and then I come back to Eric's question about Brexit.
Yeah, I gave a report at the last meeting in March specifically on the details of the prescriber, which I'm very happy to share with you, Councillor Stewart, and your analytical conversation and dialogue on that would be most welcome. But probably the thing I would like to highlight is that I think, whilst certainly not complacent, if our growth rate had been the same as the rest of Scotland in terms of costs and GP prescribing, we would have seen a 1.7% increase in costs, and we've actually seen a reduction in costs of 0.19%, which in real terms represents about £530,000 of net benefit. How that's been actually gained, I wouldn't like to be specific, but I'll cover that when we come to the next paper. Thank you.
To respond to Cesar's point, the underspend in 17-18 has been carried forward by PKC in their reserve. However, it's then been passed back to us as part of our core settlement, so we are now reliant on that to fund our core services, and it is therefore not available to offset any of the further financial risk that we're facing in 18-19. What you described would have been exactly the position we would have wanted to be in, to have a core settlement that was sufficient, and to have earmarked reserves that were there to potentially offset some of the peaks and troughs, that are particularly peaks that we are kind of facing in 18-19, but it is not there.
And finally, Councillor Drysdale, I mean, the question of Brexit is something that's probably beyond my pay grade. However, there's a lot of discussion in the press recently about some of the changes that are happening nationally. What I do know and what I can say is that as we've been working with care at home providers and people who are recruiting staff from across Europe, that the number of people who are coming forward to look for jobs here in Scotland is significantly reduced in comparison to what it was in the past. However, there are a significant population of people from Eastern Europe in particular who provide a really positive contribution to this workforce for us, and we are very keen that they should stay and continue to contribute and to feel welcome, and that there is a future for them here. That's very important as far as we're concerned, because, as I say, our native local population for the working age is pretty static, and we do need net migration in order to help that.
Thank you. The beginning of this report has got 5 recommendations, or 4 recommendations under point 1, which are all to note. I don't propose to read them all, but I think they're non-controversial, so I will note the IGB has noted all these conclusions. I think on Brexit, Eric, that it's difficult to disentangle currency from Brexit to some extent as well. You've had a semi-permanent drop of 30% in the exchange rate, which doesn't make working here quite so attractive as it used to be. With that, I think we should all take 10 minutes, 5 minutes? A 10-minute break, please, but strictly 10 minutes, and we'll come back for the next part of the meeting. Thank you. Okay, now Eric's here, we can restart. So we're back into agenda item 10. Rob.
Thank you, Chair. This is my update that I bring to the board every IJB, and this is really to note work in progress. Just before I start that, it would be worth noting that we have distributed copies of the presentation from the alcohol and drug presentation earlier. If colleagues are finding this, even this, too hard to read with some of the very small slides, small print on the slides, Val will happily email the original presentation so you can use a PC to blow it up if you need to do so. So please just let Val know at the end. So as I move into the update, you will have read the paper, and there are a couple of additional comments that I would like to make, but I'm assuming that everybody's read the basic content. Just to bring formal notice to the fact that between January and March next year, we are expecting to have a formal inspection of the Perth Kinross Health and Social Care Partnership. This is the new joint inspection regime, and we've already started our preparations. Compliments to colleagues from within Perth Kinross Council. They're bringing with them some of the experience of the recent very successful child and young people's inspection that has gone on here in Perth Kinross. So we've got an external advisor who's going to help us, and we've also got somebody who's going to be doing the work of bringing all of the information together. It's important to note that there will be a self-assessment process, and we will start getting into that as soon as possible, but we're likely to have it formally announced in September. So it's literally just a couple of months away, so the preparations are already beginning. Just to say a little bit about it, the most important thing about the inspection is not the inspection. This is about the improvements that are brought about by the activities of the Integration Joint Board and the Health and Social Care Partnership. So there will be wide involvement of all those who contribute to the board, and there will be, we will be expecting that the inspectors, as they come in, will be seeking to have conversations with members around this table, but also some of the organisations that they represent. I'd be very happy to speak to that a little bit more, but also my colleague Jackie Pepper here, Chief Social Work Officer, was in fact an inspector herself, and is therefore able to bring some of the experience of that sector to our attention. And I'm sure between us, if you have any questions, we can answer those. Moving on to the integrated workforce planning, I did speak about this a little bit earlier, and I don't want to say too much more because, as I described before, there are two particular pieces of work that we are engaged with right now. The primary care improvement plan that you're going to hear about in a presentation very shortly, so I'm not going to go into that in any detail. And then I've already described that for commitment 15 of the mental health strategy for Scotland, there is this commitment to an additional workforce. I was part of the Scottish group that was bringing this together from the Chief Officer's point of view, and we worked very hard to make sure that the definition of the additional workforce was as broad as it possibly can be, because we need to be very sensitive to the fact that each of the local situations will have different needs, and there will be some services that are already in place and they may not need to be boosted, and then there may be some gaps. So there's a piece of work to be undertaken to clearly plan that and to bring that forward as a proposal that has to be back to the Scottish Government by the end of July. Third thing I have on my update is the development of a healthy organisational culture. And we obviously are trying, in some respects, not to be too visible as a partnership. After all, what really matters is the delivery of health and care. But we also need everybody to understand within our organisation what we're here for, how we choose to work, and the way in which we choose to interact with the public. We need to have good understanding amongst our staff on the ground of what the public might expect and what we ourselves would expect of them. I want to make reference to the mental health transformation. There are three elements mentioned on the first page here. Transformation program continues, and we talked about this a little bit earlier because this connects then with the transport question that was asked earlier. Clearly, as we start to move services, it'll be very important that we make sure that the support mechanisms are in place. There was also a reference in the previous document to a change in the way that mental health services operate across Tayside, and I'm pleased to say that we will shortly be appointing to a new Associate Medical Director, and we're anticipating that this should be completed next week. We're also looking at a leadership agreement that will take every part of the mental health system across Tayside into a single purpose about making sure that pathways of care for people who happen to be close to home or needing hospital care, that they will be similar in every place. As we've heard, there are problems with certain elements of workforce, and particularly medical and nursing workforce are a challenge. So we're living with the possibility all the time of services being vulnerable to the loss of one or more members of staff. So we're working very hard at the moment to try and stabilise the medical and the nursing workforce, but we know that some of our population of nurses, they're approaching retirement in the next 2 to 3 years, and so we're having to think ahead about actively recruiting into the system. Finally, we've had a visit from the Deanery. This is the training body that oversees the training of junior doctors. And as part of the cultural issues that exist across Tayside, there is an examination of how well that training process works in order to look after not only the specialist trainees for mental health services, psychiatrists of the future, but also the GP workforce. Now, there have been a few things that have come to the attention of NHS Tayside, and we are currently working to try and address those issues. If we were to lose training status in Tayside, this would be extremely serious for the sustainability of the services in future. So this is gaining a lot of attention at the moment. It is not new. It has been known about for a long time, but we're trying our very best to address this as we speak. We have, moving on to Section 5, been working very closely with our colleagues in the public partnership, and I just want to say that in this, we met only just this week to discuss some issues of mutual interest, and the public partners were reassured that their concerns are heard and that they sit here as equal partners, stakeholder members of the board with an equal opportunity to contribute to every debate and to put their perspectives on any decisions that the board might make. We have agreed that we're going to undertake a series of actions to draw them in closer, to improve communications, and to also develop them in their role. So you will see that in the next meeting, we will probably be bringing forward a plan for the next year, at least, if not longer, which will give opportunities for board members both to be developed in their understanding of the business, to undertake visits to a number of places that our services support, and to make sure that as we develop our agendas and our business planning for the meetings, that there will be opportunity for input to that as well. Finally, as we go into the discussion about strategic planning, you'll be aware that in March we had the beginning of our next iteration of the strategic plan. The strategic plan was brought together before the start of the partnership in the shadow years. And we're enormously grateful to the people who helped with that. Something like 4,000 people from across Perth and Kinross contributed to that. However, 3 years in, we're now at a different level of understanding of our business. And it's really important now that we start to refresh that strategic plan, and we have an obligation to complete that before April of 2019. So there are a number of significant driver diagrams, some very interesting work going on nationally around public health, which very much dovetails with the core purpose of the IJB, looking at 6 areas of concern around the way in which we operate, the reach of the Health and Social Care Partnership beyond the strict boundaries of health and care into communities to make sure that, whether it be housing or economy or whatever else it might be, relationships with education, children, young people, early years, that we try and make sure that our population will thrive, and this will support us in our quest to deal with inequalities and also to deal with anticipation, early intervention and prevention. I'd be more than happy to answer any questions. Thank you, Maureen.
I just wondered, you know, under the integrated workforce planning, whether you had actually done a forecast of your programme for, you know, and if so, how long ahead? Because, you know, 5 years, is that enough? Yeah. Should it be 10 years?
It's a very, very good question. Even the medical profession, who have pretty sophisticated workforce planning tools that have been there for some time, are finding that those workforce tools are not quite what they should be. Our colleagues in nursing have been working very hard and have long-term projections about what workforce is likely to look like with the age profile of the population. There are perhaps particular issues to Perth and Kinross. This is a beautiful place to live, but it's a very expensive place to live. It doesn't necessarily attract young people in the way that a big city would attract them. And we know, as we've done surveys out of people who are graduating professions, that they do have a preference for where they would like to stay. Now, Perth and Kinross is not absent in those statistics, but when you compare it to Edinburgh, Dundee or Glasgow, it's very different. So we have to work very hard to bring young people into this area. So that is an issue that the council itself is thinking of very widely, how the economy is to grow, how the environment of Perth and the surrounding towns and villages is made attractive for young people. However, we do know that there are people who love to come and live here. Obviously, they may have an interest in outdoor pursuits or whatever, and we're looking to see how we can attract people like that, who may also bring with them the professional expertise that we require. So, Maureen, yes, we are looking forward. It isn't quite as comprehensive and as joined up as it should be, but that's the whole purpose of the workforce plan, is to look at what that more integrated way of looking at workforce might be. Where it might have been a professional in the past, it might be a support worker in the future, or a member of a third sector organisation. And it's in that space that we need to get this integrated workforce plan to a much more sophisticated level.
I was just particularly thinking about the impact of the third of the staff, you know, probably retiring within the next, or leaving for some reason within the next 5 years, you know, and if that is being written into the, you know, the strategy.
It absolutely is, Maureen, yes.
Yeah. So it will be.
Oh, it is already.
Yes.
We have the figures, yeah. Jackie?
I think that's me. Thanks, Rob. It's a question around the timing of the strategic plan. You're committing to bringing back a draft strategic plan by September, but if we're about to engage in a self-evaluation exercise in preparation for a proposed inspection, I think it would be useful to think about what would be the findings from that self-evaluation, what are the key improvement activities, so that we can dovetail the two together.
Thank you, Jackie. I completely agree. And I think this plan was set out before we knew the inspection was coming. So I think you're right, and we're very happy to work with you on that. Drew?
Thanks, Rob. So public health had a significant input to the preparation of the previous strategic plan. We're very keen to be involved in this and have had some involvement already. You and I are meeting after this to discuss public health input to the work of the IGB. So it's just to say that I'm keen that our involvement this time round goes beyond what it was the last time, which was principally around the population health intelligence line behind the plan. I've got a group of consultants and senior specialists who are keen to support you in refreshing and expanding and making the strategic plan fit with the ambitions around the public health review and the recommendations that have emerged nationally. So this is a great opportunity to embed public health and the public health approach in the strategy even more than it is already.
Thank you, Drew. As you know, I mean, I'm obviously a huge fan of the public health agenda. We've already started that dialogue in that Leslie, one of your colleagues, is a regular attender at our EMT, and we do want to make sure that there is a very close connection, so that's very welcome. Thank you very much. Colin?
It was less a question than a comment. It was just to reflect in particular on the update you gave on working with the public partners, and to say that the meeting that you and the chair and the carer and service user public partners and I had earlier this week, I thought was extremely productive, and I think we've got a good set of actions coming out of that to make that the carer and service user representation and voices are properly channeled in. So thank you for that.
You're very welcome, and I would just like to respond to that by saying that the work has already begun, and we were thinking of some very practical things that will help, as well as some longer-term issues that might help, and looking at how we make our connections even more sophisticated than they are at the moment. Maureen.
Going back again to point 4, the mental health and the transformation programme, understand that, there's an independent, investigation into mental health services in Tayside, and that that's going to be headed by the Alliance. And there's been an assurance that, carers and service users and people that will be most impacted by the changes and that will be, involved. To date, I haven't actually heard anything, and I just want it to be noted that, we will be contacted as soon as the investigation process has started, and that we will be involved, because, I would say, and I'm not being presumptuous about this, that the carers and are the people really that know the service users best and know what would help, So.
Maureen, could I, before I ask Councillor Stewart to come in, could I just declare that because I'm a director of the NHS board in Tayside, that I am not involved in the plans for that, and I am deliberately keeping my distance from that so that it is truly independent. Okay, thank you.
It was just to say, as well as sitting here, I sit on the board of NHS Tayside, and we had an update from the chairman and chief executive last week, Stephen, I think, and it was to say that the first stream of work that was mentioned in terms of the upcoming review and the inquiry by the chairman and the chief executive was the involvement of the service users and the carers, and speaking to the people who had the lived experience of the mental health services, and then they talked about and secondly they talked about the sort of staff engagement and that side of it. So the patient experience was first and foremost when they talked about how the inquiry was to be designed.
Right. So that was last week then.
Yeah, we were just sorry. Yes, we were just getting an update at a meeting of board members last week.
Maureen, the chair has not yet. A chair has not yet been appointed for this review, so the reason you haven't heard anything yet is there's nothing to hear about. But it is being put together very thoughtfully, very thoroughly. They are spending a lot of time on identifying exactly the right people to do this, and once those people are in place, I'm sure you'll hear from them. Cesar. and then Helen.
Thank you, Chair. Could we please, for clarification, that there isn't an investigation of mental health services in Tayside. My understanding is an investigation to a service and also from the GMC about a specific specialty within mental health. I think it will be important to clarify that it's not all mental health services across Tayside. Thank you.
I would just add, Maureen, to your question that we and I think a number of other local organisations have just been contacted by the Alliance, Health and Social Care Alliance in Scotland, with information about how to sign up to be involved in the engagement processes that will follow, and being able to be involved in those discussions and also submit written evidence and other things. So that's just come to us, I think, and some others, and is going out quite widely at the moment. So thank you.
So that will be passed on to the carer organisations then?
Yes.
Microphone.
Process for the workforce planning, you know, you're working with partner organisations. I mean, does the IJB have any direct input into that about maybe staffing levels, and what's the decision-making protocol at the end of the day for the staffing?
That's a really good question, Anne. Because the IJB doesn't own any staff other than Jane and I, the staffing is owned by the two partner organisations. And then obviously we have those services that we commission. And if you think into the future about how the delivery of services might be through an independent provider of services or an independent contractor, a private provider, our workforce plan needs to be comprehensive enough to be able to see all of that. But the direct control over that and the IJB's influence over it, that will come back here once it's a more formed picture for the IJB to see and probably to approve, I would imagine. However, you know, we will be working within the constraints of finance, workforce availability, and obviously the need to redesign. This is a complicated process, and you can imagine that bringing two organisations together with different cultures is one thing, but then when we start thinking about the range of people who contribute to this, our workforce is truly enormous. I was hearing just this week that there are over 900 people involved in delivering through the third sector here in Perth and Kinross, on top of the nearly 2,000 people we've got. So if you see that, and that's without us talking about the private care at home providers or the residential care homes.
A quick supplementary then, I mean, do you ever see the possibility that you might not actually come to agreement about how something should be staffed? What would happen then?
I think it's less likely that we'll have a difficulty with getting agreement than it is that we will have difficulty with supply. And I think the thing that's really interesting about this work is that we're trying to do something new and different, and to look at new possibilities of how things might be delivered. So some of it's limited only by the powers of our imagination and the regulatory frameworks within which we operate. So at a high level within the partnership, you can have very generic and integrated working. At the ground level, serving people face to face, where it's more task orientated or more routine, you can have a generic workforce, but you will never see a nurse doing the job of a social worker without the proper regulation. So those will always be defined properly, and so they should be.
Thank you, Rob. Again, at this paper there are a number of recommendations under point 1. I don't propose to read them all. Again, it is for noting, and unless anybody objects, I'll take it that the board has noted all those recommendations. We'll move on to 10.2.
Thank you. So for this, I'm going to invite Dr. Hamish Dougal to introduce this paper, and it will then naturally flow into the following paper, which covers some of the improvement plan work. So if I could just leave it to you, Hamish, to take this from here.
Yeah, no, that's fine. If folk are quite happy that I remain seated for this, there's 1 or 2 slides, but most of it's probably going to be dialogue and discussion on the GP paper subsequent to that. The engagement funding paper, which you'll see is 10.2 there, is really just an update on the paper that we brought to the board about a year ago to try and support a new approach to GP prescribing, to try and tackle the significant negative budget that we were identifying. My response to Councillor Stewart's question earlier about the growth or the cost growth within Perth and Kinross We've seen a 0.19% reduction in cost, where the rest of Scotland's seen a 1.7% increase, and both in Dundee and Angus they've seen increases at different levels as well. And that's despite our over 65 population increasing more than on average across Scotland, and very significantly more than Dundee, and a little more than Angus. So whether it's cause and effect is very difficult to say, but what we would propose is that we would carry on with this programme. It's been well received in practices. I've outlined some of the issues that we've faced in taking this forward, but I think we're now in a better position to do it with more energy than we've been able to apply going forward. I think it's important that we evaluate what we're doing, so that we make sure that what we're doing is good value for money, and is also we're able to tailor it and take the good bits out and maybe dispense with the bits that don't work so well. And so we've asked Professor Frank Sullivan at St Andrews University to do a bit of evaluation work around this, and their team are about to embark on that. I'm happy to take any questions.
Okay, we're asked to approve an investment of £211,000 in 1819 for the GP engagement programme. Are we content to do that? Okay, thank you. You have the money, Hamish.
Moving on to the next paper, which is 10.3, the Primary Care Improvement Plan. This is a very weighty document, as you'll no doubt see. It's been produced really in a matter of weeks after the new GP contract was voted through at the end of January. I think possibly a lot of IGBs were slightly slow in starting to pull this together, and I think we weren't sure how much lead we get in terms of a template nationally, but it became very clear that really what we needed to do is to pull together with a pan-Tayside approach, and this is something which we've done in recent weeks. I need to give credit to my fellow clinical directors, along with the GP sub-reps and Lisa Pruden, who managed it, and particularly also to Chris Jolly, who's sitting by my side here, who's been just come into post and was thrown into the deep end, and has been absolutely stalwart in bringing this very comprehensive document together. I think what I would like to point out is this is a starting point of a journey. This is a very broad overview. I would expect that we'll be coming back regularly to you to give you updates on how we're progressing. So it's really about mapping out a journey going forward. The basis of this here is the basis of the new contract. I need to pinch myself because I'm long enough in the tooth that I still refer to the 2004 contract as the new GP contract. And probably the main difference we saw in that contract was more about general practice funding. The big difference that would have come to the CHP or the LHCC in those days would have been the out-of-hours element, with GPs no longer taking 24/7 responsibility for patient care, but out-of-hours being taken as a pan-Tayside level. So there probably wasn't an awful lot of discussion at the LHCC in those days on the implementation of the new contract. It was a very granular contract. It was about tick boxes, making sure that patients with specific conditions reached specific targets, were given particular drugs if it was appropriate, that we documented where a patient wasn't able to take the drug, the reason for it, and it became a really granular exercise. I think, and perhaps Drew's would be able to comment about the actual impact that's had. I believe it had a positive impact in attitudes and health in Scotland, but time has now moved on, and this is a contract which is now recognising a number of things, which not least of which is the very significant difficulties in GP recruitment right across Scotland. In Perth Kinross we're currently relatively protected, but in Dundee and Angus they've already got practices which have been handed back to the Health Board. Part of the GP contract was really about spreading the workload and having a different way of working, and a recognition that the current model that we have is relatively unsustainable, as has been evidenced in different places. The main purpose of the contract is really to get everybody operating at the top of their licence, to see GPs as expert medical generalists, and to give greater access to a broader multidisciplinary team. So I personally see this as a really good, positive thing for lots of different professions, really releasing them to do what they were trained to do and to give them the freedom and autonomy to do it. This is you may not be able to read the detail of this, but historically GPs have been the term has been gatekeepers, and I've always seen it as a sort of triangle that everything that comes into my GP practice seems to have to come through a GP, irrespective of what it is, whether it's a quest for a bit of paper or a question about a prescription, and then that having taken up time then often gets routed to other people. And this is not hierarchical, this is just flow. What we're really looking to move towards, and the aspiration of the contract, is that when you go to your local GP, your local primary care centre should maybe be called, that you may see a GP first line, but actually if you've got a shoulder problem, you maybe see a physiotherapist. If you've got a question mark about your prescribing, your drugs or side effects, you'll see the pharmacist. If you've got an eye problem, you'll be sent up to the local optician, and we'll look to enhance those services. If there's a mental health issue, you'll be supported with people there. So it'll be a broad team approach, and it may be that you see a GP first, it may be that you get streamed down, or it may be for any particular problem you won't see those at all. There's also a lot of time taken up that we have for visiting patients at home, and there'll be an extension of the team there, so that it doesn't necessarily have to be a GP seeing somebody. It may be a paramedic or an advanced nurse practitioner. So it's very much a much broader team approach. The new contract the GMS 2018 contract that the government produced basically splits up the work under a number of different priorities here. The Public Health Department have taken a lead in the vaccination transformation programme. There's the pharmacotherapy services, the community treatment and care services, where a lot of tests which have been, our secondary care colleagues have requested in primary care will actually be the results for those or the people in secondary will be able to actually request the test and the result go back to them. So there's a whole governance issue about who's actually responsible for results. Urgent care practitioners, I've mentioned paramedics, and additional professional roles, again, I've mentioned physiotherapists, seeing patients first line, mental health workers, community link workers, and that ties into the social prescribing discussion that we had earlier on as well. How is this going to be paid for? There is ring-fence funds for this, so we're not coming to the IGB saying we need to find money for this. This is the indicative funds that we've been shown from Scottish Government. So in 2018-19, it's 1.249 million, increasing over the next 3 years to somewhere in the region of 4.2 million for Perth. This is a complicated governance structure, but it's quite a complicated thing, including lots of multi-professions, lots of other issues about IT and manpower. And there needs to be very, very broad engagement. As I said, we're start of a journey here. We need to engage all of the professions that are public partners as we start to look at how we actually design the services going forward. As I say, the P&K IGB sit in the red there. We expect to be coming back regularly to explain the direction of travel that we're going. So I think that's probably all I want to say. I'm happy to take any questions on it. As I say, I think we will keep coming back to you to give you some updates, but it's quite a fundamental change in primary care, and I think it will be good for patients if we get it right.
Thank you, Hamish. Does anybody have any questions for Hamish? Eric.
Thank you, Hamish. Very comprehensive paper, as you say, and it looks very much like a lot of hard work, and hopefully good news will come from this process. Given IJB's locus in this whole plan, as I understand it, really primarily it's about the money side of things. Looking at the table on page 167 of our papers, page 21 of the report, there's obviously an increasing amount of funding coming from the Scottish Government for this over the next 4 years. and that again is to be welcomed. I'm just trying to get into my head what this is. This money funding funding the process, purely the process, or is it about recruitment of people in certain places, or exactly how is this money being spent?
Exactly how it's going to be spent is to be decided. But this is about recruitment. I would say the vast majority of this fund is about new people coming into posts. So this is about recruiting physiotherapists, pharmacists, advanced nurse practitioners, and a number of different other members of the multidisciplinary team.
We had Helen.
Thank you. Around the GMS contract and the own improvement plans locally around primary care. Not surprisingly, we very much welcome as a third sector the aspirations around community link workers. We're very much at the early stages of our journey here in Perth Kinross around our plans to progress that at scale, but take the opportunity to stress the importance of third sector being a lead partner in the design of some of that layer of support. And I think that reflects back to a point Maureen made earlier about the availability and sustainability of third sector supports and services as destination points. It's complex and will require quite a fair level of detailed planning because of the interdependencies across sectors. I just had one question. I'm not sure if maybe this is one for yourself, Rob, but it was just with regard to clarity on approving the investment decisions around the Primary Care Improvement Fund. The paper notes, page 143, notes that the overall approval of investment decisions will be the responsibility of the executive management team, but the subsequent page notes that spending plans will be brought to the IGB for approval. So just for clarification on where that approval will sit.
You've got me, Helen. I don't know exactly how it's going to work, but the normal chain of events would be that up to a certain level of delegation, we would make our own decisions at EMT within a broad set of agreement that has been set by the IJB. But if there was anything really significant, that it would be brought to the IJB. However, I at this stage, this paper has literally come together in the last few days, and as Hamish has outlined, this is the beginning of a process. So as we become clearer, there will be more to say. So rather than committing to a yes or a no, or yes, this is definitely the way it's working, I think what we'd rather do is maybe clarify and come back, if that's okay.
Sorry, Rob, if I can just come in to help give some of that clarification. In an ideal world, we would develop comprehensive spending plans and we would bring them back to the IGB in September for approval. That is absolutely would represent what we would want to do. The danger of doing that is in the meantime, we need to take forward some of the plans. Hamish has mentioned the need for recruitment, and we've talked earlier about the kind of limited pool that's out there. And if we delay some of those spending plans and wait till we come back in September, we could be at the bottom of the queue in terms of being able to go out and recruit. So we're seeking the IGB to give EMT authority to take forward spending decisions, and we'll bring back the detail of those plans for endorsement, and there may have been decisions made in the meantime.
Drew, did you? Thanks, so thanks, Hamish. You've rightly mentioned the public health opportunities that were in the 2004 contract, and those were very welcome. We've taken advantage of those. That was a UK-wide contract. The great advantage we have now is this was written specifically for the Scottish context. And the challenges in general practice and primary care, there's a lot of similarities, but there's a lot of differences as well with the south of the border. What has been prepared, I think, is really taking advantage of even greater, more enhanced opportunities to pursue the public health agenda and approach in partnership with general practice and primary care in the plan. And we look forward, as I'm sure the whole of the IJB does within public health, we look forward to taking advantage of the opportunities that are there. I think there's a huge scope even beyond. You mentioned the vaccination transformation program, but almost every other aspect of the plan. there's a public health angle on those which we would like to help in delivering on those. So thank you.
I'm sorry, that I had Alan and then Maureen Cesar and Colin. I think we'll close it after that.
Okay, thanks for that, Chair. My conversation initially on this paper was around the fact that within NHS Tayside we have 3 staff side leads for the 3 integrated joint boards on the grounds of health. So you have Raymond Marshall for Dundee, you have Barbara Tucker for Angus, and myself for this IJB. We have not been cited, throughout the production of this document, not taken away from the fact that I think it's a fairly comprehensive document. And looking at Appendix 1, the contributors have all been key stakeholders, but there's been no partnership involvement in the production of this document from staff side. We discussed this on Wednesday, and I think it's quite good to get us on board at the start. And unfortunately, I appreciate Hamish saying that this has been done within a 3-week period and only shared this week. And my other point in relation to the document would be on page 28 under workforce, and looking at the 5th paragraph down where we talk about streamlining, and the wording is exactly streamlining and efficiency of grading processes. Our concern from staff side within health would be the fact that we have a clear and rigid job evaluation process under agenda for change. So the wording of that we're not happy with, and we would like to challenge the wording within that document because we have agenda for change protocols and processes that are fairly rigid. So therefore I don't understand the wording within streamlining and efficiency of the grading processes, would be my comments.
Could I just start, Alan, by saying that I have raised your concerns with Dr. Michelle Watts, who's the Associate Medical Director for Primary Care, and I've made it clear to her that it's important that staff partnership engagement is a fundamental part of the plan as we move forward. I think, as Hamish has been describing, this is at a high level at the moment. I think your point is well made. The principle is not lost, and therefore I would encourage colleagues here to make sure that that is in place for the future.
Okay, thanks for that, Rob and Hamish.
Maybe Chris would want to comment on that, the second point you made there, Alan, because I guess we're being asked to approve a document. There's very little scope. This is to go to Scottish Government, so there's very little ability to change too much of it. But what we maybe can do is take that to comment to the next IGB, because all 3 IGBs in the board need to sign it off. And if they're small amendments, albeit important amendments, but probably they're not changing the structure, I don't think they'll be contentious with other IGBs. They could probably all be incorporated into the final version. Is that fair to say, Chris?
Yeah, I don't think there's a particular issue there. I've noted your comment, and we can certainly visit that with the other partnerships. Just if there's any comfort I can give, is just to reiterate the point that Rob made about the document being at a significant high level, and that we would seek the individual chapters within this to be developed into more robust business case type documents, whereby draws on funding proposals and the staffing related to that spend we would anticipate being in the normal fashion, taking account of the points that you've made.
Yeah, I'm quite happy with that. I just think the wording on the workforce on page 28 has to be amended. We're happy with the rest of the document. It's just the wording within, obviously, the streamlining of the grading process. Just the wording, because George Docherty, Director of HR for NHS Tayside, was concerned with exactly the same wording. So it's just that wording needs to be amended.
Thank you. I think we had Suzanne next, did we? Was it Maureen first? Maureen first, then, sorry, yeah. Maureen.
On page 71 under the mental health there, the second last paragraph, current service. In many cases, those who have a mental health or well-being issue will present to their GP, and much GP time involves consultations with a mental health aspect, even if this is not the primary presentation. Now, this is obviously, you're obviously referring here to people who maybe have depression or anxiety and, presenting, but do you have any procedure for people who are obviously in an acute state of mental illness presenting at the surgery, what would be, because there's no mention of that, you know, and I think this is obviously referring to people who have lesser, you know, mental health problems.
I suppose there would be the people who are at the sharp end of needing acute care would be continue to be dealt with in exactly the same way as they have for decades. If a GP needs to see them, they will see them, you know, as is timely and appropriate, and refer them on if additional referral on is required. So that's just part of what we do in general practice, day in, day out. There's no suggestion that that's going to change in this.
No, but would they be referred on to a mental health officer, or?
It would depend on the clinical scenario, Maureen.
Yeah, but I'm talking about people, you know, in an acute state of mental illness presenting at the GP surgery, which can happen, you know.
Oh yes, on an almost daily basis, we see people in the whole spectrum of that. Some people are very, very distressed to the point that they require sectioned under the Mental Health Act and transported to somewhere where they can be safe. To the other extent that sometimes I've spent up to 2 hours in a room with somebody counselling them, and then they've gone home and we've supported them through our own support in the practice, engaging mental health services, our local CPNs and psychiatric services. So there's a wide range of responses that we have.
Thank you. And the other thing is, at one time, GP surgeries, and I think most, if not all of them, you know, kept a carer's register, because if someone came in worried about, you know, a near relative, they would, you know, jot down that they did have caring duties, and there was some sort of recognition that, you know, that person probably needed some assistance themselves. I don't think that happens now, because I think GPs aren't actually paid to do it, like, so a lot of them opted out not to do it. And it's just how we identify hidden carers, because often it's through presenting at GP surgeries that this happens. And I wondered how big a task is it to flag up the papers of that person that they're a carer and refer them on?
I think that will be variable across practices. I think what you're alluding to was there was initially a financial incentive to encourage practices to document that they had carers, and it was a bit of additional work in processing that, making sure it was in the patient record, so there was reimbursement for that. I think that is no longer the case. I could be wrong, but I think it's probably ingrained in the practice of many GP surgeries. In our own practice, when somebody registers, if they're a carer, we code that, and it's on the front screen of our clinical record, so I frequently see that somebody's a carer and can take that into account in a consultation. I think that how that is conducted is the same.
It's not across the spectrum.
It's
not
the same with
lots
of different things in general practice. The way things are documented, it's variable right across the 24 practices and the couple of hundred GPs that we have. But it's a valid point.
Yeah, I think it should be, because no other way. Well, there are other ways, but you know, it's an early, you know, stage of identifying, you know, a carer, like, you know, because carers need, you know, help themselves to cope with their caring duties, like, you know, so it's an opportunity missed if it's not been done now.
Cesar.
Thank you, Chair. I'll be brief. As a medical member not delivering primary care within this IJB, just to reinforce the fact that we very much welcome the changes in the GP contract, because we see it as not only in line very much with the medical chief officer's recommendations of realistic medicine, but also I think we feel could be an opportunity for enhancing the relationship between the primary and secondary care divide of otherwise that has been more traditional, and I think it's an opportunity for working much closer together, and very attractive to the idea of people working at the top of the license, because I think that will benefit patients and professionals in their development and achievements.
Yeah, it's might be a slightly technical question. It was just a concept which I hadn't been familiar with before. So it's in the section on IT So page 43 of the report, or 189 of 350 of the data pack, of the document pack, about the concept of being shared data controllers. I just wondered if, you know, that we checked that that was consistent with, you know, Information Commissioner's guidance or legislation or anything like that. But it might be a too technical question for anybody to come back to around the table today.
Perhaps Chris can comment if it was specifically discussed in the meeting. If not, we can go away and come back to you.
And give a little bit of detail. It has been something that we've discussed briefly, but it's there's an issue around the sharing of patient data from contractors to NHS Tayside, and it's an issue for obviously across the whole of Scotland. As I understand it, there's a change in the ownership of that data that allows that data to be shared in a way which is more fluid than perhaps was the case previously. But I can certainly come back with some more detail if that's necessary.
Thanks very much.
Hamish, thank you. I'm going to use the Chair's prerogative to have the last word here before we move to the recommendations. I thought it was a fantastically well put together paper. The overwhelming impression I had was that it is more aspirational at this stage than detailed, and when it meets the reality of NHS Tayside, it'll be interesting to see how it evolves. I wondered what the process was from here. I know you're submitting this to the government. What's the intention in terms of keeping this board informed as to progress?
I would anticipate we'd bring a series of business cases forward to EMT and share the progress of those with the IJB. A lot of those will be about the recruitment requirements for extending the multidisciplinary teams. But again, we're happy to bring them back on a regular basis for updates.
And secondly, because it's a bugbear, and you're quite explicit about the risks around the IT strategy, but presumably you'll be working hand in glove with council colleagues on their IT strategy so that we're not missing an opportunity of locking into systems and processes that become too inflexible as we evolve.
Yeah, I mean, we have ongoing issues with the different IT systems between primary care, our standalone clinical systems, and secondary care, and we add in the complexity of council systems as well. It's a huge issue you've rightly identified. And IT is very important in terms of the delivery of a lot of this stuff. So, there's a lot of conversation going on about that. Probably light on the conversations with the council systems, if I'm honest, but we can certainly take that back and see what we can be doing with that.
Okay, thank you. If we can move back then to the recommendations, two things before we go to the recommendations that are in the paper. Firstly, to note as an action point that Rob and Alan will meet out with this meeting to address the concerns that Alan's raised, and Rob will report back at the next meeting as to how that's been handled. Secondly, Rob wanted to add a 1.3 to our recommendations. So what I'll do is go through the first two and then ask Rob to add the third. So it's recommended that the board approves the content of the primary care improvement plan insofar as it pertains to Perth Kinross, and that it endorses a programme management approach being taken in Perth Kinross in respect to the ongoing delivery of changes to GMS. Rob, 1.3.
Thank you. This relates to the point that Jane was making, that we're working in an environment of short supply, and that we cannot wait for September before we begin the process of recruiting within the areas where we know we're needing to develop. So I have clumsily penned a third recommendation, which I'll read out, which is that the IJB is asked to give authority to the executive management team of the Health and Social Care Partnership to begin the recruitment process in line with the purpose of the plan, and that we can start doing that now.
So is the board content with those three recommendations? Okay, thank you.
think we covered that already.
Okay.
Stephen.
Okay. Do we have agreement? Okay, item 10.4 relates to the annual performance report and the timescales involved in publication. So what we discussed previously was that it would be taken under Chris's leadership with regards to going through the Audit and Performance Committee. I'm not sure we actually had formal agreement from the board earlier on, so can I take it we have formal agreement to the proposal that was outlined by Chris earlier? Okay, thank you. The rest of the papers are for information. I don't propose to discuss any of them unless anybody wishes to raise a specific point. Maureen?
Sorry, we're talking about the money. This is on 11.2. If we're going through, you know, all the papers that are being referred, these are all just for noting, but particularly in 11.2, there was a table where it said 19% in October, and referred to October 2018. Should that be October 2017?
I'm going to ask my colleague Kenny Ogilvie if he could answer this question in specific terms. He's just in the public arena at the moment. So Kenny, this is about the figure on page 249 of 350, which looks at percentage of people using options 1 and 2 under the self-directed support opportunities and the change in uptake from 2014 to 2018, moving from 7.9 to 19%.
Well, the question was, you've got the table there, improving choice and control to improve outcomes for the service user. We're talking about the options here. It's got percentage of people with options 1 and 2. It's got a figure for October, 7.9%, and then it's got October 2018, 19%.
Yeah.
Presumably that is October 2017 it's meant there.
Yes, sorry. Yes is the short answer. Yes,
Yeah.
it's 17 rather than 18, obviously. Yeah, sorry about that.
Okay, thank you.
Can I just jump in? Again, you asked a question earlier about the uptake in rural areas of option 1, the direct payments.
Yes. Mm-hmm.
The uptake in rural areas is actually higher in the rural areas than in Perth City. It's highest in north locality, second in the south locality, and then Perth City.
Is this SDS you're talking about?
This is self-direct support, yeah, the option 1.
Because I was led to believe otherwise, that's why I asked the question.
Okay, we have one other quick item not on the agenda. Shows the speed at which council colleagues move. It's proposed that Councillor Purvis will assume chair of the Audit and Performance Committee from when he assumes full membership of the board, and after completion of this year's annual performance report, which Councillor Ahern will complete the work on as a full member of the board until 20th of July. Is the board content with that proposal? That Councillor Purvis assumes chairman of the Audit and Performance Committee. Yep, agreed. Okay, thank you very much. I think that brings the formal procedures of the board to a close. However, there is an informal procedure that we need to do quickly before everybody's... Robert's behind the pillar. Rob? Rob, wrong way. Behind the pillar.
Attention, monsieur.
Clearly not up to date. It gives me great pleasure, Helen, to invite you just up to accept these on behalf of the IJB as a token of our thanks for your excellent work with us over 4, 5 years, is it? So thank you very much. We really wish you well. Helen's going off to do a dream job, and she may choose to tell you a little bit about it, but I'm very excited for her future. But we will really miss Helen. She's been a significant contributor to not just the board's activities, but the relationships that we've struck up with a whole range of people that I would never have met had I not got to know Helen and the team. So thank you very much, Helen.
So who's going to look after Maureen's microphone? That's what
You'll have to be here in September to find out. Thank you very much, everybody.
Sorry, folks, before I go, could I just draw your attention to one thing? It's right at the end of the agenda today. 24th of September, there is an opportunity for board members to attend an event in Edinburgh which is going to give specific training on the standards that are expected of board members. I would really encourage those of you who can go to go. It's important that we conduct our business in a very sort of upright and proper manner. So thank you very much. That will really help us. Thank you.
If I can just add to Rob's words there, as the standards officer, I would commend it all to you because I think it would be really useful for you. It's across Scotland, so it's not just IJB members from here or from Tayside, it's across Scotland. So it's an opportunity for all IJB members to hear stories, share experience and so on from across what's been happening in the last couple of years across Scotland. So I really would commend it to you. Standards officers will be there as well. So we've already had a session swapping stories, so now it's your turn.
I take it substitute members would be expected to go to this too?
Could I just say that I'm pleased to hear that because the Coalition of Carers already runs events quarterly for all IGB carer reps on the boards across Scotland, and it's a good opportunity to network and find out what's going on in other areas. And I think the public partners have a similar event, you know, now too. So it's good that you're all getting a chance to do it now.